One Health approach to tackle antimicrobial resistance through public procurement of innovation, we learned that, according to recent estimates, 1.27 million deaths were attributed worldwide to infection caused by bacterial MR in 2019, with predictions showing bacterial MRL could kill 10 million people per year by 2050, without any prevention and mitigation measures. Economic study by the World Bank and the Organization for Economic Cooperation and Development reported that from 2015 and 2050, the cost of MR will be $3.5 billion per year for the expenditure on healthcare alone. Today, we will go through several presentations on the RaDAR project, RaDAR procurements, MRA management, and cross-border collaborative public procurement of innovation. I would like to propose you to do a short exercise. While listening to the sessions, let's reflect on whether we are able to answer to the following 4 questions. Is combating MR a priority? Maybe we have already an answer. Can cross-border collaborative public procurement of innovation help to address the current challenges in MR management? Has RaDAR taken a step in the right direction? Should we keep pushing forward along this path? Before moving to the presentations, I would like to begin the exercise by referring to 3 documents. The first 2 are reports commissioned by the European Commission and released in 2024. One of them is from the EU Rapporteur on the future of the single market, Enrico Letta, former Italian Prime Minister and member of the European Parliament. And the second one from the EU Competitiveness Rapporteur, Mario Draghi, former Italian Prime Minister and President of the European Central Bank. Using their words, public procurement represents a key tool for disbursing public funds within the European Union and serves as a major catalyst for economic activity. Accounting for 14% of the EU GDP, public procurement is formidable instruments to spur innovation among European startups and scale-ups. To untap the potential of innovation procurement, on top of enlarging the importance of other award criteria beyond price, public buyers should be directed towards promoting social value, enhancing social capital, and aligning with the EU ambition for green and digital transformation, and requiring products that are based on common standards and are interoperable. With both satisfaction and humility, recognize that there is still work to be done, we can say that RaDAR was already designed to contribute to the vision later outlined by Letta and Draghi, even before the reports were written. Promotion of social value. RaDAR is proposing needs-driven solution to fight antimicrobial resistance and leading this transformation from a public provision healthcare perspective. Award criterion beyond price. In the wide range of RaDAR contracts, you will listen later during the morning, we can see the weight of the price is going from 20 points to 60 points, over 100, depending on the contract and the lots. And this leaves room to award criteria as technological plan, operational plan, quality plan, change management plan, and evidence generation plan. Digital transformation. There is no innovation adoption without a transformation. And this is exactly what is happening at each of the buyer side. They are now doing their own transformation. The fact that transformation in digital enables to start measuring what we were not measuring and gather the relevant data to benchmark the before and the after and start to generate evidence. Common standards. Buyers different in nature and across Europe. We have 2 university hospitals. We have 1 research institute, health research institute. We have 1 GPO. We have 1 regional centralized laboratory service from different countries, Italy, France, Spain, Country Basque, and Catalonia. Agreed not only on a common set of requirements, awarding criteria, and monitoring strategies, and also a not payment scheme, but also agreed on a common set of indicators to measure during the contract execution. These common data sets opens the door. We are not there yet. Still, we know that we have work to be done to study the impact of the different transformations and contrast elements like governance, risk sharing, payment schema, while fighting the MR. European startups. During a market sounding radar received a major interest from the industry with 67 responses, whose majority were SMEs. Overall, the majority of the 17 radar lots distributed across 5 contracts have been awarded to SME. And now let me add a third document that was just released. The encyclical letter Magnificat Humanitas, released by Pope Leo XIV. Independently whether you're Catholic or not, but I'm Italian, so for us the Pope is important. I invite all of you to read it. There it is highlighted that technology innovation are not neutral, for they can either foster participation and justice or exacerbate inequality, control, and exclusion. And also it is mentioned that politics has the task of orientating economics and technology to the common good, promoting dignified work, social inclusion, and an equitable distribution of the benefit of innovation. I interpret these words as an invitation to continue moving in the direction initiated by RaDAR, to further strengthen the dialogue between the public and the private sectors, and to reduce inequality, control, and exclusion, while promoting dignified work, social inclusion, and equitable distribution of the benefit of innovation. So right now I can just thank all the consortium partners for making this journey with us, and Aquas team members for their coordination and their work. Thanks to the contractors to support the digital transformation of radar buyers and contribute to the fight against anti-MR. Thanks to all the speakers for contributing to the event. Thanks to the audience here today here with us in the room and remotely in participating to this collective exercise and proposing. And thanks to COSME, Program and ESMEA, for taking the risk with us and makes RaDAR happen as the first collaborative value-based procurement of innovation project. And thanks to Axio in Generalitat Catalunya for hosting RaDAR last event today. Thank you all.
Thanks, Rossana, for these inspiring words. Now I will like to give the floor to Giovanna D'Adamio, that is the Program Coordination Manager at ISMEA, and will also give a welcome and a presentation. Thanks a lot, Giovanna, for coming.
So good morning, everyone. It's a pleasure for me to be there and to celebrate the achievement of the RaDAR project. So first of all, I would like to congratulate the project partners. Yes, you made it. As the previous speaker said, it was challenging. Yes, we took the risk at ISMEA, but we are confident that there are a lot of stakeholders that can make the most of our funding programs. It's with a little bit of emotion that I'm here to close this project, because this is the last project that we are closing funded under the COSME program. So the COSME program ran between 2014 and 2020. We are now almost at the end of another programming period. We are managing the single market program. And as you can see, although the project was funded under COSME, it still had a long duration. And we are happy that the time invested for this project has brought significant. Okay, sorry. Okay. As you know, my agency, ISMEA, mainly focus on support to SMEs. We have the European Innovation Council that is supporting innovative, groundbreaking SMEs. We have then the single market program that supports SMEs that are still innovative, maybe not unicorn, ready to internationalization and innovation. And one of the things that we have noticed is that SMEs sometimes do not take into account participation in public procurement. That is, in any case, a good opportunity for them to, let's say, to do business, because sometimes they cannot sell their product. Because in order to sell, you have also you need also a buyer that is ready to onboard innovative solutions, that is digital enough to deal with them, that has a staff that is ready also to use those solutions. This is why we started under COSME, and we are continuing under the Single Market Program to support SMEs by supporting also public buyers, meaning helping them to get ready to take on board innovation. And this is not only to use innovation, but also to request, because when you publish a call for tender for purchasing innovation, you need to know how to draft, for example, a call, how to address the public and you want to reach. So this project, RaDAR, and the twin sister, it was another project called Drug Detector. Maybe I know that some of you maybe got in touch with the beneficiary running this other project, are two successful examples of what we are doing. It all started in 2022, if I'm not mistaken. I know that these are projects that needs a very long, that are usually very long, because they need also a very long preparatory phase. But I'm happy to see that results are now there. If I'm not mistaken, you have been running 5 call for tenders that have been successful. You will maybe present them today. You are better placed than me to show the results. And I have to say that although these projects are successful, today I cannot give you a reply to a question that you may have. Will there be a follow-up? The answer, I do not know. But I can tell you that we are running other projects targeting public buyers and stakeholders, including innovative SMEs, to bring them together. We have, for example, the public buyer platform that is running, and it's aiming at, it's a community of practice for public buyers, also per sector. So you may have public buyers in the sector of health, efficient energy, etc. So if you are not familiar with the platform, I invite you to have a look, maybe also to register at in this platform, and to be proactive as member of the different fora. Then we have also we have launched a couple of years ago also another project that is titled Procurement Hubs. This is also aims at helping stakeholders to embrace public procurement of innovation. And under this project, we have recently launched a call for expression of interest addressed to buyers, so public buyers, in order to benefit from consultancy support. So even if you are not a buyer yourself, but if you know, I'm sure that you have a network, I invite you to get in touch with them to make them aware about this opportunity. I'm here, of course, to represent ISMEA, but I have to be honest. I mean, I'm program coordination manager. The project has been managed by another colleague of mine, that is Marco Iaquito. We cannot be there today. So I'm not taking his credits. I'm going to pass the message to him that everything was achieved. And I know that you are also in touch with another colleague of mine that is Darian Peric, that is going to accompany you towards the end of this project. This afternoon, you will meet my head of sector, Igor Kalinic, who will moderate one of the session you have planned. Unfortunately, I will be able to stay here in the morning, not in the afternoon, but let's say it's a very busy period for us at the moment. We are busy with a big evaluation. I thought I touched, sorry. So I would like to conclude by saying that even if the project is coming to an end, there is never an end, because we always care about the sustainability of the project, the dissemination of results, and the transferability of results. For this, we count on you. It would be really a pity if once the achievements are put in a drawer or in a cupboard and the cupboard is closed. I'm sure that there are lessons learned that you can share with your peers, that you can share with policymakers, that you can share with us at agency level, because you know that there is the policy making and there is the program. Maybe there is something that you have liked, there is something that you have not liked. Maybe we can also improve as contracting authority, as granting authority, to facilitate, let's say, access to EU funding in the future. So please do not hesitate. It's an end of the chapter, but it can also be the beginning of a new chapter, with or without EU funding. I will stop here, reiterating my best wishes for you and give you a round of applause for your achievements. And I'm curious to listen now to what the project has delivered. Thank you very much.
Thanks, Joanna, for the kind words and the best wishes that you gave us. And thanks for coming and being here today. Now is actually my turn to present an overview of the RaDAR project. Yeah, so if you can... Maybe I need to... Yeah, I have it here.
¿Puedes avanzar? Avanza.
Ah, no. Perfect. Thank you. Thank you. So my name is Maria Pont Vizcarra, and I'm an innovation project manager at Aquas. And at Aquas, we are the agency for health, for quality and health evaluation in Catalonia. And we are also the coordinators of the RaDAR project. As Giovanna also explained, RaDAR is an European project co-funded by the COSME program. And RaDAR stands for Rapid Detection and Control System for Antimicrobial Resistance. And as the name indicates, the objectives, the main aim is to address the urgent need of rapid detection and effective infection control systems for AMR. And we are doing this through the implementation of a value-based, cross-border, collaborative procurement of innovative solutions, so a PPI. A bit of, so I will give you now an overview of the project and the methodology that we used. But first, I want to go back a few years ago, because RaDAR comes from another project that was a PCP project that was called Anti-Superbugs. Anti-Superbugs was a PCP that started in 2016 and finished in 2022. And in which Aquas also participated as the lead procurer for several buyers that were from Spain, from Catalonia, Italy, Germany, and UK, and some also supporting entities. And Anti-Superbugs had the challenge of finding a way to rapid detect microorganism and its resistance mechanism, because without that, we were not delivering appropriate treatment or appropriate antibiotic. So the idea was to have a surveillance and infection control system based on prevention, reporting, and prompt intervention. So that's where RaDAR comes from. So from this PCP, we move to the RaDAR-PPI. So now I'm going to give you a bit of an overview of the RaDAR-PPI consortium and the RaDAR project. RaDAR started, as Giovanna also said, in January 2022, and will end now in the next month, in June 2026. RaDAR had a total budget of 4.3 million euros, with a contribution from the European Commission of 2.5 million. And RaDAR is a consortium of 11 partners, from which 5 of them are public buyers. So we have 5 public buyers from Italy, France, and Spain. Those buyers, as Rosanna also introduced them a bit, are RESA, that is a central purchasing body in France, which had a procurement budget of 900,000 euros, and the procurement was divided in 10 lots. Then we also have Institut Català d'Oncologia, ICO. It's an oncology institute or oncology hospital in Catalonia, close to Barcelona. And they had a budget of 800,000 euros, and the procurement was divided in 3 lots. Then we have also the University of Naples Federico II, the Public Health Department. We also call it UNINA, in Italy, in Naples, and they had a procurement budget of 150K, and they did one procurement not divided with lots. Then we have Laboratorio de Referència de Catalunya, that is a reference laboratory, with a procurement of 200K that was divided in 3 lots. And the last buyer is BioGipuzkoa, that is a health research institute that had a procurement of 100K and also not divided in lots. And then we have 6 supporting entities. Among the supporting entities, Aquas, the entity that I represent, that we are also the coordinators. Then we have also INSERM, from France, that are also the coordinators of another program that is a joint action called JAMRAI. Then we have INSME, that is from Italy, and is helping us with the communication of the project. So also many thanks for the help on organizing this event and all the dissemination. Then JERA, that is from UK, that they are experts in public procurement. Consorci de Salut i Social de Catalunya, that is a Catalan GPO, and Hospital del Mar. And Hospital del Mar is doing the procurement together with the Laboratori de Referència, also in Barcelona. They are a general hospital. So from here, let's move to the methodology used. So at Aquas and also in other innovation projects that we did, we follow a step-by-step approach, starting with the needs identification, the needs assessment. So first, we identified what is the problem and the needs that we have, and we verify those needs, we prioritize the requirements, and we build a business case. From this first step, we move to the market assessment, the innovator's readiness and feasibility to solve that problem, the needs that we have. And for this, we do a state-of-the-art and horizon scanning and also market consultations. So with this, we know if the market is ready to provide a solution for the needs identified, and if the solutions available are mature enough to solve the problem. Then we move to the adopter's feasibility, so the buyer's feasibility. And here we identify which procurement are we going to do. In the case of RaDAR, with the public procurement of innovation, among other options that there are available. And we do this having clear the reimbursement schemas, so also agreeing on risk-sharing mechanisms and payment for results. But this is not a step-by-step approach that we follow one after another, but it's an iterative process, and some of the steps overlap also. And that is important because we are not doing the first one without taking into account also what would be the reimbursement schemas, for instance. So this is the methodology that we also followed at RaDAR, but actually we went one step further. That is that we did a coordinated cross-border procurement, because the procurement was coordinated among the different buyers, and also cross-border because the buyers are from different countries. So we had this common preparatory phase in which buyers and all the partners from RaDAR work together to define first the clinical demand, and then also the market readiness assessment with several market consultations. From this common preparatory phase, we move to the publication of the tenders, and each buyer published its individual tender per locality, and also each of them execute their tenders individually, but this execution was monitored in a coordinated manner. So let's now go kind of a bit step by step, the process that we follow at RaDAR. So first of all, what's the problem? Rosanna also talked a bit on her introduction about the problem. So in 2019, there were about 5 million people that died from illnesses in which AMR played a role. And from those, 1.3 million were as a direct result of AMR. So if things continue as they are, or they were in 2019, there will be more deaths than cancer by 2050. So this also supposes a high economic burden, 1.5 billion euros annually in healthcare costs and productivity losses in the EU. So we can say that the manner in which we treat infections now will endanger our health in the future. So then RaDaR also had the need to respond to the Joint Action on Antimicrobial Resistance and the EU Action Plan, in which we had the aims to improve early detection systems to ensure quality care process, screen drug resistance and virulence to improve treatment effectiveness, reduce both healthcare and governmental costs, and also report and rapid communication to increase system resilience. And we had a good example of how important this is from the COVID-19 pandemic. So from here and knowing what are the needs, we followed a multi-layer approach to understand the AMR context of each buyer group. This needs identification and clinical demand definition was led by ICO, Institut Català d'Oncologia, this multi-layer approach went from analyzing the macro level of each of the buyers, so the global context policies and objectives of each institution regarding their national guidelines, action plans, policies, etc. So more in the macro level. Then we move to the meso level. So which agencies are in charge of AMR strategies, the levels at which AMR protocols are implemented, so the strategies that are taking place, etc. And from this, we move to the micro level. So the processes, workflows, methodologies, the tools used, and professionals involved in the management of AMR at each of the healthcare institutions. So for instance, this is the workflow before the RaDaR implementation. So we established which one was the workflow from suspicion of infection till treatment and patient follow-up. And from this process, from this workflow, we identified all the points in which we would like improvement, the common pains that we had from this process. And I will not list all of them, but for instance, lack of screening facilities, complex sample extraction, slow diagnostic tests. There were also difficulties for communications between the important stakeholders, difficulties for key patient data visualization. So from those needs and those pains identified, we move to the definition of the clinical demand. And that also followed a process. So first, from all the needs identified, we prioritized the needs. And we did that using semi-structured questionnaires that were completed by healthcare professionals from all the institutions from the RaDaR project. From the needs that were prioritized, we also validated and discussed those needs with experts. So both internal experts from the RaDaR, but also external experts took part of focus groups and interviews to help define the clinical demand. We also did an inventory of pathogens and multi-resistance detection systems, and we took the input from the business case that each buyer did, and and the market readiness assessment to define the final clinical demand. So in parallel, because it was not one after another, but were done in parallel, we also did the market consultation, and this was done in 4 different steps. First, with early notification to the market. We wanted to make the market aware that the tenders were coming early enough so that the market would be prepared. So we did this notification at the beginning of the project. So quite before in advance, the actual tenders were going to be published. But the market then was aware. Then we did the market sounding. So we would have a discussion with the companies. The companies could say what they had available, etc. And then we moved to the market consultation events, and we did 5 consultation events. 4 that were local, 1 per locality of the buyers, and 1 international one that was online. And then after those market consultations, we also did bilateral meetings with suppliers. So the buyers met individually with the different suppliers interested to know what was available. So some results from the market participation. As I said, we did 5 market consultations. More than 160 participants we had in the market consultations events. From those, more than 50% participated in the market sounding. We did then 48 bilateral meetings with suppliers, and from those 48% were SMEs that participated in those meetings, and the participants were from 12 different countries. So now let's move on the methodology that we used for building the call for tenders. And we use the theory of change methodology. And this methodology follows a reverse engineering logic. So we start from the end. So what is the long-term result that we want to achieve? What is the impact that we want to achieve? From there, we move to the outcomes, so the mid-term results that are needed to achieve the impact. And from there to the outputs, so the short-term results needed to achieve the outcomes and the impact. And in order to assess those results that we want to achieve, we involve all the stakeholders, including patients and citizens, healthcare professionals, the healthcare providers, the health system, the more general socioeconomical and environmental impact. And then with this methodology, we could assess what is the impact that we wanted to achieve with RaDAR, that is to having an infection prevention control system and an appropriate treatment. And for this, we wanted to improve how AMR is managed in 4 different sectors: patient, pathogen, sample, and prescription. So we wanted to improve those 4, so patient, pathogen, prescription, and sample management. And the short-term results were that we wanted to improve the way that the healthcare professionals were able to visualize the data and to support, to have support for pathogen and on-site management. So from those results, we could then define all the activities that were necessary to achieve them. In the case of RaDAR, here are all the different activities, but they are grouped in 4 categories that are MDRO detection, training and support, information access, visualization, and data aggregation, and the last one that is interoperability. So from those all those activities, each buyer selected the ones that were that they were more interesting because of the needs that they have, but also the budget that they have available, the risk that they wanted to take, and the specificities of each institution. Because as I mentioned before, we had a quite broad, quite different types of institutions. So depending on that, each of them selected the activities that were more important for them and also taking into account the other specifications. What is also important is that we want to generate an evidence. We want that those contracts are permeable to value. So by using the theory of change, aligning it or having the inputs from all the stakeholders, aligning all the activities with the different professionals involved. From the activities selected, we build the call for tenders by taking those activities and transferring them as requirements for the call for tenders, linked to specific KPIs to measure those results, and to be monitored, to evaluation elements, and always having a clear payment methodology also. From this framework, each of the buyers, and also taking into account their specifications, each of the buyers published its own tender. So we had 5 tenders published, one per buyer, but always taking into account that we want to generate an impact that is the same. So we have the same final result that we want to achieve. And for that, and in order to evaluate those aspects, we also had common KPIs, a bit different depending on the specificities of each buyer, but common KPIs to evaluate the evidence that we generated during the intervention. And the results included reduce the transmission, reduce the nosocomial infections, and also reduce the length of stay. So from here, so each buyer published its own tender. There were 18 contracts awarded to 15 different companies. I'm not going to enter in detail on the results of that, because each of the buyers will now explain exactly sorry, always moving alone. Each buyer will explain the procurement that they did and the results that they have. So I just want to give you some details on how we did the monitoring and evaluation. So after the contract signature, there was a kickoff meeting, and also the governance of the contract was reviewed. And then there was the implementation phase, and the implementation phase was divided in 3 steps. First, the change management, in which there was the first process of adjustment of the service provision, so like changing, right, that workflow that we saw at the beginning to the workflow that would be now with the new solutions, training the professionals. And this phase ended when the solution was integrated and ready, and we also had a report from that part. And then we started with the deployment phase, in which the solution was up and running. And in those deployment, we had the periodic collection of the results obtained, KPI calculation, and at the end of the first deployment phase, we asked for an interim outcome report, so the first results. And at the end of the project, at the end of the deployment phase, we had also the evidence that we generate, and also an end of the project report to know exactly all the results achieved by the project. And during all the implementation phase, we also compile the lessons learned, both from the buyers and also the economical operators, because we want that the next time that we need to do something similar, we can do it better. So we are gathering all this information to be able to apply it in future procurements. So now, some of general outputs from the RaDAR project. All the results information is published in the website, so if you have any doubt, question, I'm happy to also answer the questions, but you have all the information on the website. Rosanna also mentioned, so I will not go into details, some of the deliverables that were public and were published recently, as the handbook and the One Health approach to tackle AMR through PPI. Those will be discussed also briefly this afternoon with presentations from Rosanna and Luis. We also have a report from the market sounding and the market summary that was from when we did the market consultation. At the YouTube channel, we have all the videos also from the presentations we did, etc. So if you have any question, you can review that. But I wanted to highlight that we did a series of animated cartoons that we call the RaDAR collaboration series, in which we explain a PPI adventure against AMR. So it's a series of videos explaining how we did PPI in a more divulgative way, which I think they come out quite nice to first understand what is PPI and what we did. And also on the Zenodo community from the RaDAR project, we have all the information available there that will also last forever, hopefully. With that, I wanted to thank first the whole RaDAR consortium for all the work in those 4.5 years. We work hard, but I think we also have very nice results. And I also want to thank you for your attention and for coming here to the final event. And now I don't know, I think maybe we have some time for a few questions if anyone has. No? Perfect. Then I think we can move actually to the following speaker. And now we will start that each of the buyers will explain their solutions, what they procured, and the results that they have. And the first one, we have Unina, that Madalena Ilario will show us their results.
So thank you, Maria, and I would like to thank you especially for the privilege of being our coordinator, because it has been really a pleasure, and I would like to thank Aquas and the extraordinary team that Aquas put in place to support us. Rosanna Holman patiently helped us and supported us to become, to transform the challenges into a push to overcome our limitations. We have a lot of limitations in the implementation of antimicrobial resistance. So I am an endocrinologist by training. I have a background in basic science. So for me, the challenge of antimicrobial resistance is really special, because I see the world through these little plasmids that transfer genetic resistance to antimicrobes. Our hospital is the largest facility in southern Italy, bridging care services with research and also training and education. And we have 750 beds and provide many outpatient and inpatient services through a multi-site building. We have 25 buildings. And that is a logistical challenge for any implementation we usually undertake. You have already had a look, you already had an overview of the process that we implemented in RaDAR, and we focused our needs identification with an interdisciplinary approach that brought us to focus on rapid detection of common microbes and strengthening an integrated and smart management of antimicrobial resistance in our hospital. We carried out this double consultation, engaging small companies, small and medium companies on our territory, and we established an interdisciplinary network of experts and stakeholders to finally define our demand. Being a university hospital has an advantage that is easily accessible, quote unquote easily, to especially clinical experts across a number of specialistic areas, but we also involve the nurses, because nurses play a very important role in implementing innovative approaches to antimicrobial resistance. We had some struggling interaction with the digital experts, because we have a number of data system and data flows in the hospital that lock in the possibility to integrate innovative solutions. So that was a struggle. We have been involving intensive care units for adults and neonatal care units, because they have an issue with antimicrobial resistance. And last but not least, we have administrative staff. So I have to say, I was really important to hear from ISMEA that there is a platform to build the capacity across administrative staff, because this was, unless it was for the strong will of a couple of people in the administrative staff, it would have been impossible to overcome the constraints of the Italian digital platform to publish the tenders. Because in our case, for example, this was a very simple problem. We had 150K lot. This is under the threshold for publishing an open bid. And we needed to do a targeted appointment. But we preferred to open the consultation. And this blocked the system digitally. So it was impossible to retrieve the first effort, administrative effort. We had to redo the entire procedure again, agree with the officer that as we had only one company interested, we could do a direct appointment, and then we lost like 6-8 months, I think, just to give you a taste for the complications. So the results of the needs analysis in our hospital setting focused around the 3 pillars. The first pillar is the quick identification of common infections. And this was very important to improve prescribing of antibiotics. The second core cluster was around the monitoring of antibiotic-resistant infection, and this was done through the integration of data with the hospital system, and we could not achieve this, but at least we managed to share the data of the pilot across the different clinical clusters thanks to the platform. And we strengthened the surveillance system in the hospital. And last but not least, we implemented an innovative approach to prevent hospital-acquired infection in the hospital. This is a very simple journey of infections management in our hospital. We focused on inpatients, so the journey starts at the outburst of clinical signs and symptoms of infection that following which we implement a few rapid tests that we have available at the hospital. Then the treatment is either empirical or deferred, depending on the number of tests that are requested by clinicians. And then in the meantime that the microbiologist comes back with the results, we wait or we, as I said, prescribe empirical treatment. Then the results come back and the therapy is revised and finalized, and then eventually there is a control. Our call for tenders reflects the 3 priority blocks that I showed before. First of all, the point of care, so a system for accelerating the detection of the type of infection, common infection, an integrated clinical decision support system that should be rooted in the surveillance results that are monitoring the hospital, and then the interoperability of the IT system. The KPIs have been, you have seen already the key outcome, and the KPIs we picked are in line with the aim of improving management of patients, pathogen, prescription of antibiotic of the sample, and also improving the general acceptance of the innovative solutions, working on usability and acceptance. So we have been focusing on the optimization of prescription of antibiotics and improving the timeline of the diagnosis. Now, I don't know if there is a connection from Kalion, but I would like to thank Kalion because they have not been only the provider of the solution, they have been a partner for us because it takes more than a provider to address this kind of complex implementations, and they've been flexible enough to adapt to the different groups that we were involving for the implementation. So I don't know if there is anybody from Kalion connected.
Thank you, Professor Ilario. I'm here. I'm Andrea from Kalion, Andrea Granata from Kalion. Can you hear me?
Anyways, Kalion Antimo is the platform, the integrated platform.
Can you hear me?
Yes.
Okay, good. So they're better than me at explaining the solution. Hi. We cannot hear you, and now we see you, but don't see the slides anymore.
Can you hear me?
Yes, now we hear you.
Yes.
Do you want to share the slides from desktop, maybe?
Thank you, Professor Ilario. Can you share the screen? Because I
cannot. So.
Okay. Well, I will share the slide from Kalion perspective.
Ho detto, meglio che le condivido.
Can you see the screen?
Yes.
Thank you, Professor Ilario. I will now briefly introduce Antimo from Kalion perspective, focusing on the value created together with UNINA within the RaDAR-PPI process. The key point is that Antimo should not be seen only as a software platform. In this project, it was framed as an operational tool to help transform microbiology and rapid diagnostic information into decisions that can be used by clinicians, microbiologists, infection control teams, and hospital governments. The platform was developed around three main clinical objectives. The first is to monitor antimicrobial resistance in hospital and community settings. The second is to support clinicians with timely and contextual information, so that data become usable at the point of care. The third is to guide antibiotic choice through evidence-based recommendations, supporting antimicrobial stewardship without replacing a clinical judgment. The four modules shown here reflect this logic along the care pathway. The dashboard gives visibility on AMR trends and risk areas. POCT integration brings rapid test results into the workflow. Guidelines support treatment choices and prescribing quality. The Learning Hub helps disseminate protocols and sustain adoption over time.
We cannot hear you anymore. What did you do in the technician?
For us, the co-created value with UNINA was precisely this, moving from isolated technological components to a shared workflow connecting rapid detection, surveillance, and stewardship. I will now go into the first module, the dashboard.
In projection mode, you are not...
Sorry.
That's fine. No.
Can you see the screen?
Yes, but you are again not projecting the slides.
I think I have a problem with PowerPoint.
But I see the slides in PowerPoint.
Okay, thank you.
Oh.
Okay, the first module is the dashboard. In the context of RaDAR and of the UNINA case, this module is important because rapid detection and microbiology data generate value only if they can be read, interpreted, and shared across the organization. The dashboard gives real-time visibility on resistance profiles and on the spread of resistant pathogens across different settings. It allows the hospital team to monitor AMR patterns, identify high-risk areas, and follow trends over time. The interaction with UNINA helped us understand how important the level of granularity is. Data must be available not only as general epidemiology, but in a form that can support operational decisions. For example, the same information can help understand what is happening in a specific world, prioritize attention on specific organisms, or measure whether an intervention is producing an effect. So the key message is that Antimo makes microbiology information easier to read, easier to share, and easier to act on. The next model brings this logic closer to rapid detection and point-of-care testing. The second model is the integration with point-of-care testing. This is the area most directly connected with the RaDAR challenge of rapid detection. Antimo supports workflows for rapid identification of pathogens and currently includes tests such as flu, pulse SARS-CoV, Clostridium difficile, Legionella, and RSV. The value here is not only that the test is passed, the value is that the result enters a structured clinical workflow. The platform supports registration, execution, and result handling, helping users follow a consistent process and reducing manual transcription. Another important point is interoperability. Antimo was designed so that additional rapid detection systems can be integrated through interoperability standards. This is relevant for future scenarios because the rapid detection landscape will continue to evolve. A hospital platform must be able to absorb new diagnostic technologies without forcing the organization to redesign the whole workflow. From Kenyan perspective, one of the strongest lessons learned with UNINA is that rapid testing creates maximum value when it's connected to action, timely clinical decisions, infection control measures, and structured reporting. Once diagnostic information is available, the next step is to support appropriate treatment choices. The third model is guidelines. This component helps connect diagnostic information to treatment decisions. Starting from the diagnostic suspicion, Antimo can present recommended treatment options and make clinical guidance more accessible at the bedside. This is particularly relevant for antimicrobial stewardship. In many organizations, guidelines exist, but they are not always available in the right format at the right time or within the clinical workflow. Antimo helps bring those recommendations closer to the moment of prescribing. It also allows prescribing behavior to be compared with guidelines, supporting audit, quality improvement, and reduction of inappropriate antibiotic use. A key design principle is that the platform supports clinicians but does not replace them. The objective is to provide structured and contextual information, leaving the final decision to the responsible healthcare professional. This is important in a complex institutional environment such as UNINA, where antibiotic decisions depend on patient condition, local epidemiology, available diagnostics, and stewardship policies. The guidelines can also be customized at national, regional, or local level. This makes the module adaptable to different hospitals, departments, and evolving stewardship strategies. Finally, adoption and sustainability require structured training and protocol dissemination. The last module is Learning Hub. This is particularly important when we speak about PPI and co-created value, because innovation is not complete when the technology is installed. It becomes effective when people understand it, use it, and integrate it into their daily routines. The Learning Hub provides a centralized environment for procedures, protocols, guidelines, and training materials. Content can be uploaded, updated, and organized in one place, so that teams have access to consistent and current information. It can also be delivered by role or by operational unit, which is useful in a hospital where clinicians, nurses, laboratory staff, infection control teams, and managers have different needs. The module also allows training progress to be monitored. This is relevant for antimicrobial stewardship because stewardship is not a one-time intervention. It requires continuous alignment, dissemination of protocols, and enforcement of good practice. For Kelium, the main value of the RaDAR-PPI experience was the opportunity to co-design with UNINA a practical bridge between rapid detection, AMR data, stewardship decisions, and organizational adoption. Antimo is the digital layer that helps make this bridge visible, measurable, and usable in daily clinical practice. This closes the Antimo overview and connects back to the wider UNINA and RADAR lessons learned narrative.
So if we can go to the next slide and maybe I can I? How does it work now? Okay, so this is the way the service process looks now. Essentially, what happens after admission to the hospital, the POC kicks in and supports clinicians for early detection of common viruses so that the differential diagnosis with bacterial infection and viral infection is immediate. And that is done just before the samples are drawn and sent to the microbiology lab. And there have been a number of positive impacts of this integration, especially also because the Antimo solution, as you have seen, has the opportunity to be flexible, modulated to support clinical decisions. Just a step back to the overview of the implementation of the contract. We have been implementing our activities through 3 phases. The first one has been very intensive and it involved the change management. You will see how hard it can be to put them together when I show you which departments were involved. And the multi-building localization of the different departments was a further complication. So we needed to have differential on-site adjustments and testing acceptance. First of all, conceptual acceptance, because at the end of the day, the nurses were at the forefront of the implementation of the POCT and of the surveillance system. So the change management was very successful. For once, the technologies didn't let us down. They were very effective. The installation of the system in the 6 planned departments was on time. The configuration and the functionalities of the POCT devices was done also timely. And the access to the platform was ensured to all stakeholders of the different operators. And finally, we could demonstrate before the pilot began the workflow of the activities according to our RaDAR implementation. So the units involved in the study were adult ICU, geriatrics, infectious disease unit, neonatal ICU, pediatric surgery, and then we replaced the neck surgery department with the internal medicine of another, because that surgery could not do the project. So we had the availability, the opportunity to involve a community hospital. And this community hospital was from local health agency Caserta, Marcianise Hospital, and they also have the emergency. So that was especially interesting because the internal medicine colleague was using the POCT to titrate the admission from the ER. And that was really important because it allowed to prevent the outburst of flu epidemic in the inpatient rooms, because they could separate and isolate the patients immediately. And also, I was talking to her yesterday. We are going to retrieve the data about the length of stay in internal medicine, and it seems, I don't want to be too optimistic, but it seems that the length of stay is reducing compared to the average of the case mix of the same hospital from the previous year during the epidemic. The rapid test that the clinician chose, because this was the results, so you have to understand that to arrive to this to an agreement for the 4 tests to make it took us many meetings. And when you are waiting for a clinician to come from the ICU, the meeting is basically an open door, because each one of them shows up at a different time. So this was very pragmatic, because they have emergencies, they have things that happen while they are moving to come to the meeting. So you have to be very flexible, but they really wanted to do it. The nurses were very involved. So in the end, they agreed to do respiratory syncytial virus, RSV, Legionella, A and B flu, SARS-CoV-2, and Clostridium difficile for gastrointestinal infections. So these are the tests we purchased. Then there has been a distribution between the different units. And at some point, we internally shuffled some tests that were not being used during the flu pandemics. We reshuffled some lots of tests to the internal medicine of the emergency because that's where they were most needed. And we decided to give them the opportunity. The training module was focused around 3 main content. And the first part is we actually took the opportunity to recap a bit with all stakeholders what's the relevance of antimicrobial surveillance and how the RaDAR project could be useful for them. This was very important to motivate them to stay engaged. The second part was we took the opportunity to revise the hospital procedure in terms of infection control and prevention of antimicrobial resistance and we discovered that some of them needed updates because it had not been updates, so we involved the clinical lead of the hospital. So it was a very interesting opportunity. And finally, we landed on the real teaching of the integrating of the point of care into the clinical practice. So we had to decide where in each of the setting of the different clinics the tool should be placed, who should be in charge, and because this was also kind of a conversation between microbiologists and nurses, because when nurses don't have it in their, it's not their job to do the POCT, but microbiologists are not enough. We have like 4 or 6, so it's impossible for them to take over the control of the POCT in the different clinics. So they agreed it was like a sort of informal hub and spoke model. So the responsibility was of the microbiologists and the deployment was of the nurses. So they did, that's why it was important. They trained together, and this is still informal organizational change. Actually, the changes in the hospital are formal only where they end up into the performances of the hospital. And if I have to say, we are still very far from reaching a change in the performances for this. But at least in the daily practice, this is done. As I said, there was a good participation to the training. We had a total of 47 participants in presence. I wanted the training to be in presence. And mostly there were clinicians and nurses, but also biologists and other people, some from my team and some others from the communication. This is the research protocol. It's much simpler than it looks like. And basically, it's a multi-center study between our hospital and Marcianise Hospital, the one in Caserta province. It's a single-arm study targeting patients hospitalized with a clinical suspicion for infection. The intervention is the RaDAR system, and the outcomes is the evaluation of primary and secondary endpoints that are focusing on the effectiveness of the new system to detect specifically the targeted infections. And the secondary objective is the time that it takes in comparison to the time of the routine microbiology testing. We enrolled 103 patients, and the age was between 0 and 95 because we have the neonatal the neonatal intensive care unit, so we had some newborns. And we have an average age of 50, and actually the 57 actually, and the distribution between sex is pretty balanced. Most of the patients are admitted from their home, from the community. We have part of patients that have been transferred from other hospitals. Some of them are born in the hospital, and some of them are from nursing homes. There was one patient coming from jail. We deliver services for jail patients, and I wish I could have extended the study much longer to have a subset for this population, because I think that jails are a really serious hotspot for antimicrobial resistance and deserve a better attention. Here you see the time. So first of all, no, here is the sensitivity and specificity. So the test had very few, if none, false negative, which is very good. just a few false positive, and this places the test as being very effective, because false positive is okay, false negative would have been a problem. So we have 95.8 specificity rate, and this is true for flu, for SARS, Legionella, RSV, and Clostridium. And this is a comparison of the time. So, you know, there is a big average of time of the time it takes the microbiology lab to give us back the results. It depends a lot on we have a chronic shortage of professionals in our region, because we have been living a contingency measure since the last 20 years. This means that human resources turnover has been frozen for 20 years. This means that we are chronically understaffed. So when I compare, I've been doing a comparison between number of beds and number of human resources, and we more or less have 1/3 of the human resources you have in your hospitals. I've been doing comparisons with Germany, Austria, Spain. So we are totally understaffed, especially in terms of administrative personnel and nurses. So this is why also you see the average time to have back result is 13 hours. It's a long time, but it's not, it's the average, because sometimes you have a festivity, so you do not have enough people to cover the shift, and there are a number of reasons. So but anyways, the median of time to obtain the results from the POCT is 4 hours. The average of the microbiology is 13, so the math is very simple. So it's very convenient to have the POCT, and is a very strong improvement. And the number of patients that are isolated, out of 18, there was 1 false positive and 17 were isolated, which is very good. Now, if we look at prescription. So in the first block, you see we enrolled 103 patients. 60 of these 103, according to WHO guidelines for appropriate prescription of antibiotics, I'm finished. They should have been treated. But using the POCT, we only prescribed antibiotics to 40 of them, and this is very good. And of the patients with a positive POCT result, 60% did not receive antibiotics. Now, we are not, the limitation is that we did not consider additional diagnostic tests, but the trends are very, very interesting. This is usability and satisfaction are very good. Actually, everybody liked the test. The only negative expectation is the problem, because when we started, we expected to integrate with the hospital record, and this would have allowed us to target AMR and MRDO, but we couldn't do it because we were missing a number of pieces information, and so we could not do it. But overall, this is a very strong, good, positive results. And I just had one last slide that I don't see, that was about what comes up next. We are planning to integrate in the local health agency in Marcianise the digital solution, because they have an in-house IT system. So they are not, do not undergo the lock-in system from the companies handling the data flow. And we would like also to customize the implementation of the RaDAR solution on surgery, for the wound healing, and also for the handling the devices of critical patients that are the 2 hotspots, and also to strengthen the integration of the training and education package with the bundled documents, because these checklists that are used by nurses are, in the end of the day, the terminal. What is really useful for them, you can print them, put them on the wall, link them to QR codes to obtain immediate suggestions on operational guidelines, and this is what we are planning to do, and maybe look for funding also in national cause. Thank you so much. I don't know if there are questions. Okay, thank you.
Thanks, Maddalena, for explaining all the insights from UNINA. I think you have very nice results. Now it's time for a break and coffee. So we have 15 minutes. There is some coffee, some pastries, and some fruit. So please, it's just outside. See you in 15 minutes. Perfect. So it's now the moment to continue with the presentation from Institut Català d'Oncologia. As I mentioned before, ICO is one of the oncology centers in Catalonia. It's one of the main reference centers for oncology, and it's located very close to Barcelona. Ana Álvarez, project manager at ICO, and Òscar Martorell, and also Francesc Güell from Cefate will present the different solutions. So Ana, Òscar, the floor is yours. You have the presentation here. Yes. Oops.
Good morning, everyone. And thank you for organizing this meeting, and thank you for being here. It's a pleasure, after a lot of years working together, to be here for the end of the project. It has been an amazing journey with all of you. So my name is Ana Álvarez, and I work as a project manager in the Institut Català d'Oncologia, ICO. And I will present today the case of our hospital. So the Catalan Institute of Oncology is a public institution dedicated almost exclusively in the field of cancer. And it is an institution that combines not only attention to the patients, but also prevention, also training, and also research in a single organization. And it is the reference cancer center for the 50% of the adult population in Catalonia. So it is around 3.5 million people, reference center. And I will talk a bit about our context first. So the patient profile of our hospital is that we treat oncohematological patients that are often immunocompromised, and these are patients with more frequent antimicrobial treatments, are often medicalized. So with all this, we have a higher incidence of AMR. That's why rapid detection is essential for the correct management and also the prognosis of the patients. So this time between the infection and detection and action is key for their prognosis. After a needs identification phase where we work with a lot of professionals in our hospital, we finally prepared a tender and a procurement process based in 3 different lots, aiming to have an integral solution to manage how we treat antimicrobial resistance in our hospital. So we have a lot for the rapid detection of bacteremia or sepsis. We have another lot for screening in the admission of the patients to detect MDROs at the admission of the hospital. And we have a third lot that is based in a software, so an IT system for the better control and prevention of infection and how we manage infections at the hospital setting. I will talk a bit about each of the lots. So first, the bacteremia or sepsis. Why we ask for this lot? Because we have some needs, because we have highly catheterized patients, immunocompromised and neutropenic, and there is a high risk of bloodstream infections and also rapid clinical deterioration. So early detection of bacteremia was identified as a critical clinical need. Because we need a faster microbiological diagnosis to enable timely target treatment. It would be performed in the event of symptoms of suspicion of infection according to clinical criteria, prioritizing some specific vulnerable situations. This lot was awarded to a SMI company from Valencia in Spain, that is Durviz, that distributes this technology that is CubeDX. It is an Austrian company that distributes this technology that the difference from the traditional method, that is the hemoculture, is basically the time. So we pass from days to have the definitive result to 3 to 6 hours to have the direct results without the need of having an hemoculture. And we have a broad molecular panel, so we can detect bacteria, fungal species, and also resistant genes. And it's only needed 9 milliliters of whole blood of the patient. This technology is based on preparation of the sample and then amplification and hybridization after the detection in the PCR. And as I said, it's direct from the whole blood. So the results, I will give you some results after that, but we are doing great, and we have a great concordancy with the hemoculture method. It is true that the company is now working in automating more the process, as it's still a technique that requires some hands-on, sometimes or some time of a technician working in the lab. So hopefully in the future we have a more automated technology that allow us to have it in the routine in the hospital. Then the second lot about the screening of MDROs. We ask this because we have, as I said, high vulnerability to healthcare-associated infections and silent MDRO colonization. And it would allow us to detect and prevent hospital transmission and outbreaks. It also would enable us to timely implement and or discontinue IPC measures. And it would strengthen patient safety in a high-risk oncological setting. And it would be performed in the admission screening based on some risk criteria. And this lot was awarded to a company that is the Fate, that we have here, Frances, that will explain later the case, with this GenExpert system that is based on amplification of some of the target genes of resistance that are Staphylococcus aureus methicillin resistance, carbapenemase, and also vancomycin resistance. And it allows us to detect this colonization or infection in about 45 to 50 minutes. So now it is not like an innovative test per se, but the way that we are using it is the innovation, because we can now do it in an admission in the hospital, so we can prevent before this infection goes to the hospital. So when we admit a high-risk patient and it is admitted to the hospital, the healthcare professional can examine the risk of colonization and perform the test. And in about 45 minutes, we can discontinue the preventive measures and the isolation of the patient with resources and the workload that it has for the professional. And or if it is positive, we can proceed with the isolation and precaution measures, avoiding infections and outbreaks in this hospital. And the time is what may make the difference, because we had before the culture that it can take up to 3 days to have a result. So we had some gap there where we could have some outbreaks or infections, or we would be using a lot of resources to contain that. And after that, we have the love of the software. The requirements that we found is because we needed to centralize patient microbiology and IPC information that sometimes is very hard to find in the information system in the hospital. Also, we needed to have real-time communication of AMR between laboratory and the professionals at the hospital. And we needed better coordination between clinical and IPC teams, better surveillance and traceability and monitor of MDROs, and faster and more efficient clinical decision-making. So what we needed is a tool to make the life easier for professionals taking decisions at the hospital. And this lot was awarded to the Informatica Medica group, that is a Catalan SMI. And with this big IRAS platform, that we can see here a bit how it looks, but it allows us to have a smart management of infection at the hospital. And as you can see, we can have the graphics of what is happening in real time. And we are now finishing all integrations at the hospital, and it allows us to transform this, the lot 1 and lot 2 data, but also laboratory data, to have it in one system, allowing to have some real-time alerts for communicating the results. Also allowing to give different tasks from a colleague to other in the hospital, to have easy access to the guides and the workflows, and also the protocols, and to have a retrospective surveillance and tracking what is going on, so we can make action when it's needed. Also, I had to say that Informatica Medica, we have some representatives here today, and they have this nice tablet where they can show how the platform works, if you are interested. And with all this integral approach that we did in ECO, we can have not only rapid detection, but also AMR management. And with all this, strength, prevention and control measures, reinforced communication, the stewardship programs, and have close patient monitoring. Finally, having better care for the patient. This has been a long journey with all the teams involved in the project, and it was also an opportunity to share decision-making with the frontline professionals of a hospital, so they understand how workflow works at the hospital, they understand what is needed. So it was a nice opportunity to rethink how we work and how we approach AMR. In our case, we had a timeline adjustment because a PPI is a complex instrument, because a public procurement of innovation is a bit different of a usual purchase at a hospital, so it took some time. We had some administrative delays, but we found the mechanism to that allowed us to finish the execution of the contracts, and we finally had an agreement with all 3 companies, so we can have the end of the project instead of June in December 2026, and with Informatica Medica also 2 more years. So we can have some more results, and we can finish with this really important project for us and for our professionals. So it was a lesson learned that I think is important to take into account for future projects. We need to, when we do a proposal, to be sure of the capacity of each institution and to be realistic on timeline. And also I think authorities and funding authorities can take into account how complex it is, and also find these mechanisms to be flexible so we can execute the project with finally all this done. And so the case of ECO, it was an opportunity to rethink how we work in AMR, and it was also an opportunity to reinforce infection prevention and control, antimicrobial stewardship, precision real-time patient monitoring, and it was a way to evaluate find an optimal approach to AMR, and make some improvements not only for patients but also for professionals, and very important to try to keep our antibiotics and antimicrobials working in the future. And as we say in the EU JAMRAI, with the nice pin that you have here today, because we love our antibiotics. So Thank you very much. And Oscar will present some of our preliminary results. We will have the opportunity to have another event in Barcelona soon. We will keep you updated and to present some more results, but thank you very much.
Well, well, thank you so much, Anna, for giving me the word, and also Maria for the introduction. I know it's presenting, I think. Oh, yeah, that's right. So thank you so much. So leave me be here presenting all the results. Well, I just give you a brief summary of these preliminary results that we obtained. Can you hear me? Yes. Yeah. Okay. Thank you so much. I know if you can hear me well. Thank you so much. Well, first of all, this table shows that we have this. Can you see this course? Okay. Well, first of all, I have to mention that we start collecting this data in February 2026, and we are still carrying them out, performing all these tests. So if we focus the number of the tests performed, we can see that we have 14 cases of bacteremia tests. Then we have 174 tests of load screening of carbapenemas and vancomycin resistance. And finally, we have 20 tests of the methicillin-resistant Staphylococcus aureus detection. And the results shows the percentage of concordance with a conventional laboratory above the 90% in all of the cases. And the time to get all these results has decreased. In fact, sorry for that. We can see that a lot of bacteremia, the time to result is approximately 4 hours. And in the case of load screening, we have 46.6 minutes and 61.2 minutes. So if we consider that a conventional microbiological culture takes around 3 days, this means that we have a time reduction of 94 to 98%, which is, we think that it's so significant. In addition, these results are related to microbiological diagnosis, but what about the epidemiological outbreaks that can be prevented with in the hospital? So we have some lists that some cases that we can rapidly detect it in these months. For example, we identified 5 cases of vancomycin-resistant Enterococcus faecium and a carbapenemase resistant Klebsiella pneumoniae, thanks to the screening test. And we also detect an ESBL resistant Escherichia coli through the bacteremia test. So, what do these results imply? Well, I think that these results allow us to take measures. We think that these measures can be split in 2 groups. For example, we have the measures related to the hospital and the measures that are related to the improve the patient health. We focus on the measures related to the hospital. We have the resource optimization and cost savings. For example, if the diagnosis is improved, and so that means that a possible treatment is also improved, the number of the hospital stays or the stay days will decrease. So it's that means that we have a cost saving. Then we have also a bed management, because the slide before I was talking about the positive results, but I think that the negative results are also a significant value, because that means that a negative test allows us to avoid unnecessary isolation, and only we isolate when it's necessary. And also we have the enhanced epidemiological surveillance, that it's, in this case, it takes importance the software, because we have a connection between the real cases, the measures that we take, and the decisions of the clinicians can approve or disapprove. And these decisions can perform in real time, which is, I think, it's quite significant. And finally, regarding the measures taken to the patients, well, we have, for example, if we establish an accurate diagnosis that enables a better prognosis and survival, then we will have a more target and less toxic treatments and a reduction of the hospital stay, as I mentioned before. Lastly, I want to mention that there is a lower risk of transmission because, as I said, the isolation measures only happens when it's necessary. And also the coordinate teams between the microbiology department and the clinical department, I don't know how to say, all this coordination gives a better result or gives us a better performance, and I think it's an integration of all of these stuff. So that's a simple review of all the results that we are collecting. So now I leave the words to Francesc Güell, who is an expert of the technology that we use to the screening lot, and we have many results. So it's ready to come. Thank you so much.
Perfect. Thank you very much for inviting us to showcase our technology in this event. Thank you especially to all the RaDAR consortium, but especially to Aquas and Institut Català d'Oncologia, our close partners in our experience. In 1879, Charles Chamberlain developed the first modern autoclave, revolutionizing medical sterilization. Before its implementation, surgical infection rates were over 40%. Today, thanks to technologies such as the autoclave and other strategies that have been implemented around these technologies, have fallen around 2 to 3% on clean surgeries nowadays. This advancement not only saves millions of lives, but also laid the foundations of a culture of safety that we continue to build today. Just as the autoclave transformed medical practice, we are now facing another technological opportunity: the use of rapid PCR for screening at-risk patients on hospital admission, being it the basis of an infection control strategy through the use of diagnostic testing, specifically the symptomatic screening of carriers of carbapenems-producing Enterobacteriales, MRSA, and vancomycin-resistant Enterococcus. The objective of my quick presentation today is to show you how rapid PCR has been embedded as part of RaDAR project to reinforce patient safety through the reduction of the AMR spread in hospitals. We are CFATE. CFATE is a worldwide company with over 6,000 global employees, 1,400 employees in EMEA, and reach patients over 180 countries. Our portfolio has 31 rapid PCR tests for virus and bacteria identification through our what we call our GeneXpert system. The GeneXpert platform is a highly scalable and extremely easy to use platform delivering the highest precision of PCR while simplifying the on-hands processing. All starts with the sample collection. You can see the swab. The sample goes into the cartridge goes into the system, and around 1 hour later, the magic is done. The result is ready for the clinical assessment. These systems are different sized according to the setting that clinically are best localized. You can see at the lower part on the right, the hospital lab systems. We can also place them in emergency departments, in physician offices in primary care, in sexual health clinics, checkpoints, in nursing homes or intermediate care facilities, and also even in public health offices or pharmacies, depending on the country that we are talking about. We have done that. What was the role of the GeneXpert on the RaDaR tender? For this project at the Instituto de la Oncología, CIFAID provided the GeneXpert rapid PCR solution to detect, as I said before, 3 targets: the carbapenemase-resistant Enterobacteriales, the methicillin-resistant Staphylococcus aureus, and the vancomycin-resistant Enterococcus. These 3 pathogens are recognized by the CDC as a major AMR threat and are included in the CDC February 2025 call for action to member states. They are primarily transmitted in hospitals and other inpatient care environments. These 3 tests enable CPE-MRSA invariant screening for, in this case, in this project, oncologic asymptomatic patients at risk of carrying this bacteria at admission, and help protect vulnerable patients themselves and also other vulnerable patients that can get in contact with them during their admission, preventing exposure and new colonization. What's the value for the patient and for the healthcare system? In 6 bullet points, we can say that an early detection prevents transmission, identifying carriers in high-risk patients avoids new colonizations, and reduces asymptomatic spread in the hospital. It supports AMR control because it limits the transmission of resistant organisms and contributes to AMR containment efforts. So it optimizes antibiotic use, reduces unnecessary exposure to last-line antibiotics, and enables more targeted treatments. It protects antibiotic effectiveness and slows the development of resistance. It improves the overall patient safety in the hospital by decreasing healthcare-associated infections, as we said before, preventing outbreaks, because it's a preventive approach which prevents outbreaks. And it also drives system-level impact in Spain because it creates a strong synergy with the antimicrobial stewardship program, what we call PROA in Spain, improving the overall results on AMR reduction. This is interesting because while PROA, antimicrobial stewardship, reduces the wrong indication of antibiotics, in this case, we reduce the need of exposure of patients to antibiotics. So it's a synergy that less patients will be needing antibiotics and better antibiotics will be prescribed. And last slide. Our takeaways of the RaDaR value-based procurement project. It's very interesting for us. It was a real opportunity to sit at the table for innovation for first time that we did it in Spain. RaDaR gave us the opportunity to discuss directly how our technology could support public health priorities. The procurement focused on outcomes and not only on price, and that's also valuable for us. Because we are in a better position to show the value of our technology. The process helped connect our value proposition with real system needs and patient outcomes. We also valued very much the openness to listen and explore where innovation could add value through the market consultations that were very key for us to understand what was the need and to make us understand what were the capabilities of our technology. So we can reach until here, and we have this need. So then the match was possible thanks to this communication. This project is showing another interesting thing, which is it shows procurement as a policy driver. RaDAR shows how procurement can actively shape public health strategies, not just purchase products. And that's interesting because it helps healthcare policies to move forward. Healthcare policies move forward sometimes is a risk. Value-based procurement, this pilot project, is de-risking innovation for buyers, and that's another good thing of it. Piloting is a structured framework that reduces the uncertainty before broader investment decisions are made by the different decision makers and the governments, at national and regional level in Spain. But also, it can suppose a scalable model for Europe. This approach can be replicated to strengthen healthcare systems preparedness across different countries, supporting the very recent ECDC IPC guidelines that were published this month, implementation. So this is one tool that can support the implementation of these IPC guidelines. Thank you for your attention.
Thanks, Francesc. Thanks, Anna. Thanks, Oscar, for your presentation, for your input. I think it's also very valuable to have the vision from a company in the perspective of PPI and the results from ICO. So now it's the turn of Laboratorio de Referencia de Catalunya that, as I said, they are procuring in association with the Hospital del Mar. And Eduardo Padilla will give a presentation on their results. So I will...
Okay. First of all, thank you very much for being here. For me, it's a pleasure to stay here with you. I would want to thank anyone involved in this important project, especially to Aquas for the organization of this event. Thank you, Olman, and thank you, Maria. And forgive us the new opportunity to present our project, no? With our project, as you say, is finished at February of this year, and we have also preliminary result that I'm very pleased to share with you. Okay, in fact, our project is a travel. It's like a travel in which participate three public organizations, the Hospital del Mar, el Laboratorio de Referencia de Cataluña y el Consorcio de Salud y Social de Cataluña, with a shared journey, no? With objectives and with an end, no? The finish of the project, in which we try to get our goals, no? Our objectives. Let me introduce myself and all our partners. My name is Eduardo Padilla. I'm the head of the microbiology service of Laboratorio de Referencia de Cataluña. This laboratory is a public laboratory network serving more than 20 hospitals within the Catalan health system. Here you can see a map with the distribution of all these hospitals. Only have a note that the main hospital in our network is Hospital del Mar, that is located at the city of Barcelona. The second partner, sorry, I have more things to say from our laboratory. Our laboratory promoted since 2022 a project named DB, that is a biomedical and imaging diagnostic network, and is one of the first public initiatives to unify the three core diagnostic domains: clinical laboratories, anatomical pathology, and medical imaging into a single and a unique and coordinated network. Currently, there are more than 700 professionals working in our laboratory. We perform annually a total of 18 million of analytical determination. This make you an idea of the dimension of our laboratory. Now, yes, this is the second partner, Hospital del Mar. Hospital del Mar is a healthcare institution that provide services to a population of more than 300,000 inhabitants. They have 461 beds for acute care patients, attend more than 140,000 emergencies every year, and have realized more than 17,000 surgical interventions every year. The last partner is the consortium of el Consorcio de Salud y Social de Cataluña. This is a community-based public association comprising more than 100 health and social care organizations. Here in this slide, you can see the 7 main objectives of these institutions. But in resume, this institution provide services and representation in the field of health and social care for people for acute and for with longer-term care needs. Well, now we are going to tell about our project. Our project aims, or the objective of our project is to reduce multidrug-resistant microorganism transmission inside of the hospital. By this manner, to try to reduce the number of nosocomial infection due to or produced by this kind of microorganism. To do that, we use the 3 complementary and synergistic interventions. 2 of them are performed in the laboratory, the 2 of them, and 1 in the hospital setting. The intervention performed in the laboratory, so 1 is the rapid detection. It's a new approach for rapid detection, screening and detection of multidrug-resistant bacteria from colonized patients. Our sample clinical are in reality surveillance samples, and also a prospective epidemiology by using the whole genome sequencing technology to looking for similarities, genomic similarities, to aid to the clinician to take decision. And finally, the third intervention, and I think the more important intervention, is those that is performed in hospital setting and is realized by the infection control teams. Okay, in detail, the project inside the laboratory. What do we do in the laboratory in this project? Well, this is the first intervention. That is the rapid screening method for that allow us to detect the multidrug-resistant bacteria in patients that are under surveillance system in some specific units of the hospital. All is patient at risk And the units are oncology, hematology, nephrology, no? Units like this. Every week, we screen all the patients in these units and use this methodology. It's a phenotypic approach. It's different that this that you showed before in the ECO project. This is not a molecular approach. It's a phenotypic approach. My opinion have their advantage, but also have any disadvantage in comparison with the molecular method. No? The time to detect in our case is 7 hours, and molecular test, as you can see before, is around 1 hour. No? It's important the difference of 6 hours. I don't know. This is we can talk very much about that. No? But in my opinion, the phenotypic approach allow to detect more microorganisms multi-resistant than the molecular approach. Okay, with this with methods, we are able to give a negative result in 7 hours. This is very relevant, as I say before Anna, because clinicians can take control measure. No? For example, stop the isolation of the patients, no? or help to the clinician to select the best empirical treatment also. No? Okay, as this is a screening method, negative results are definitive, positive result must be confirmed. Okay, for that reason, we use a second step in this first intervention, that is use on positive result of immunochromatography approach for the detection of the main resistant mechanism. Is a extended spectrum beta-lactamase, that's ESBL. In the future, we name that as ESBL, and carbaphenamase production. We obtain positive result, that is preliminary results, in around 8 hours. Okay, this is in this slide you can see a report of it's a real report of this in our laboratory. Above you can see that we reported the Klebsiella pneumonia with Carbaphenamase oxa-48 and one Escherichia coli with a beta-lactamase with extended spectrum beta-lactamase. This preliminary report is available for the clinician at 8 hours when we receive the sample in the laboratory. Okay, the second intervention is the use of whole genome sequencing methodology to characterize genotype bacteria and to try to investigate the similarity between these bacteria. No? And, we apply this method directly from isolates from clinical samples and from surveillance samples, for all kinds of samples. And all the weeks we perform this test for all the multi-drug resistant microorganisms that would isolate during the week before. No? This approach we will call as prospective epidemiology, because we do that before an outbreak is produced. A conventional method use this technology when outbreak is present, and I think that is not very useful for clinicians, no, or to take measure for the team of control infection. No? This is an example of a report. In green, you can see basically we do with this methodology is compare the genome of the bacteria, no? and decide how differences in nucleotides is necessary to consider one bacteria similar to other. No? We use a cutoff in this study to 25 differences in nucleotides. In green, you can see, and all the strains are compared with the other one. No? In green, you can see those bacteria with less than this cutoff, and that we considered that there is clonally related. This is other way to show our results using these figures or dendrograms or phylogenetic trees, in which you can see the difference on distance of the similarities between bacteria. Well, all these things occur in the laboratory, but what happened with this information? No? Logically, this information goes to the clinicians. We have this part very close with them. Immediately, when we have the results, is informed to the clinician, and in this moment, they realize control and prevention measure to avoid transmission of multidrug-resistant bacteria, and with this strategy, decrease the number of nosocomial infections. Okay, it was very important in our study for the exit of this kind of study that a very good coordination of the laboratory with the clinician. No? And during this project, we are able to build a culture of rapid response. No? We think that successful implementation required coordinated change management across multiple stakeholder groups, transforming institutional workflows and establishing new standard practice. For us, very important that to provide rapid results and to obtain rapid response, clinician response, no? In the coordinated manner. No? Okay, our results. This is the result for the first intervention. Remember, this is the screening of multidrug-resistant bacteria in patients under active colonization surveillance. We are able to discard, to rule out in less than 8 hours the percent of around 50% of extended spectrum beta-lactamase and the 75% of carbapenemase. This is very important information for clinicians. And we are able to obtain a 25% of a ratio of positivity that is a 5% more that we use in comparison with the previous year by using conventional methodology. Inside of the first intervention, the second part is the use of immunochromatography for positive results, no? And we are able to detect the 90% of total of ESBLs and the 98% of carbapenemase using this approach in less than 8 hours. This is very important and very important results also. With respect to the result of the second intervention, we realized it performed a total of 546 whole genome sequences, and we found 99 clonal relationships, taking account that each of these clonal relationships is informed immediately to the clinician, and the clinician initiate intervention to avoid transmission or to looking for the origin of the multidrug-resistant bacteria. And we do that every week. Instead, every month or 1 month later that outbreak is produced, that this is the way in which we work the year previous. The idea is to try that the outbreak don't to avoid outbreaks, not to act once outbreak is presented. Okay, here is the more important results. Laboratory results are important, but the more important results are clinical results. This was our clinical key performance indicators that we decided to use at the beginning, at the start of the project. Is the nosocomial infection rates, multigraft-resistant organism prevalence, beds blocked due to isolation requirements. This is the three more important, and then we are in a phase in which we must to know what cost have this, no? With the cost of this KPI, no? Well, this is our results, our preliminary results. Using this approach, we are able to reduce in 67% the number of nosocomial infection in comparison with the year anterior, taking into account that we are comparing from July, October on 2022 versus July, October 2025. Okay? Not only we reduce significantly this nosocomial infection, that also the blocked beds for isolation decreasing in 10%. No? And all these results with an increase of detection of multi-drug resistant bacteria in colonized patients. No? This is an amazing result that we must to study carefully, but indicate that our approach is it's okay for our objective. No? Not all was easy. We found barriers for implementation and sustainability of our project. We need, for the success of this kind of project, I think that is necessary. And 24 hours a day and 7 days a week of microbiology of the presence of the microbiology in laboratory. Microbiologists must validate results 24 hours a day. Also, it's important that there are something in the other side to do something with our results. Okay, clinicians must be attentive to this result and act rapidly. And finally, we need human resources to do this kind of approach. In this project, we need a technician of laboratory to perform all the technical part of microbiology lab, and a clinician specifically dedicated to this lab during the project. No? Now we have not these resources, and now the project is finished for us. No? It's impossible to do it without resources, human resources. And we discovered 3 pillars for operational sustainable practice. No? Is that, as we mentioned it before, it's very important, the coordination between laboratory and all persons involved at the hospital setting. We need to improve the workflows every day, no? Based on practical experiences and the outcome data. Finally, we need automation. We need to automate the automation of process. Clinicians work very manually. To find epidemiological relationships, we need these tools, specific software or artificial intelligence tools, to find this epidemiological relationship between patients. No? Okay, as a conclusion, we can say that the combination of the 3 interventions that I showed you, together with the coordinated implementation between the laboratory and the infection control teams, resulted in a more than 60% of reduction in nosocomial infection and enabled the availability of a 10% of hospital beds for isolated patients. And finally, next steps. What are we going to do now? What are we doing now? First of all, we must calculate these clinical indicators that I present here, because this figure are very 70% of reduction is a figure, important figure, and we must take into account the entire study period, not only 4 months, the 8 months complete, and comparing the result not with 2022, compared with 2024. That I think that we obtain more realistic results. In my opinion, it seemed to indicate that the result is not being very different that I showed before. And in the second, we need to conduct an economic analysis for the impact of reducing the number of nosocomial infection and the decrease of in beds occupied by patients with multidrug-resistant bacterial infection. We must do this economic analysis, and with those data, we are working to prepare a document justifying the implementation of the project finally in the Hospital del Mar, at the Hospital del Mar, and its future scalability in other hospitals of Catalonia, and why not in the rest of Catalonia. For that, we have the support for this task. We have the support of Aquas, Bincat, and I want to thank you for continuing with in this travel. I am very optimistic and that we can find a solution to the final implementation of this program. Okay. Thank you very much.
Thanks, Eduardo, for the explanations. I think very nice results. Hopefully very soon we will have the final indicators to really know the comparison with a more recent year, but the indications are very promising. So thanks for the explanations. Now is the turn of RESA. As I said before, is a central purchasing body in France, and Ines here, project manager at RESA, will explain the results together with Lorraine Belavan, that will join online for the explanations from the Nosotec side. So Ines, I will help you with this.
So hello, as said, I'm Ines Jambois, European Project Manager in the international team at RESA, and we have Laurent Belevance from Nosotec, who is honoring us with his presence online. Perfect, the slides. So I will begin with a brief presentation of the RESA. RESA is a central purchasing body acting at national level in France, whose objective is to help and support their beneficiaries in improving their performance. At RESA, as you can see, we had 3.5 billion euro of procurement volume in 2025. We have more than 1,000 suppliers with 54% of startup and small and medium enterprises. Also, we are the first healthcare public player to obtain the Responsible Purchasing and Supplier Relationship label. We have more than 4,000 beneficiaries, including every French hospital center. And this number of beneficiaries helps a lot with the diffusion of the market, notably. In addition, RESA created its own innovation center to support the identification and procurement of innovative and sustainable solutions. Beyond its core activity of purchasing, RESA provides strategic procurement support, logistic and change management services, leveraging the expertise of its knowledge hubs. At the European level, RESA is an active participant in EU-funded projects and the co-founder of EPA, which is the European Health Public Procurement Alliance. It's a network of 11 public and non-profit central purchasing bodies dedicated to the healthcare sector across Europe. At RESA, we have 12 procurement categories. So we offer tailored procurement solutions which cover all needs of its beneficiaries, across these 12 procurement categories. I will now explain the RaDAR's role in the RaDAR project. RaDAR is the only central purchasing body that actually bought during the project. As we are a central purchasing body, we were able to offer several lots. We have thought of this market as a whole and offer a global market to tackle antimicrobial resistance. RaDAR was leader of the Work Package 3, value-based collaborative procurement definition and coordination. We assisted the other buyers with their purchasing strategy and answer questions regarding their specifications. We were the purchasing expert of the project, so we define and coordinate the purchasing strategy. We assist other buyers based on their individual needs, organize regular follow-up, share good practices. We also elaborate guides in each language, so French, Spanish, Italian, to help startup and small and medium enterprises to apply to the call of tenders. Then we coordinate the publication of the calls for tenders, coordinate the evaluation of the offers, the contract award and the signature of the contract. The French guide that we developed during this work package is now used by our innovation center at RaDAR and is accessible when startup or small and medium enterprises want to answer a call for tenders. So we were the pilot of the purchasing strategy, and it was an individual cross-border procurement, as said by Maria in the introduction. So at the end, everyone wrote their own. So there were common unmet needs that were told, notably global solutions. And furthermore, each buyer has specific unmet needs based on their local specificities, such as facilities, resources, and screening priorities. Notably, the duration, the contract scope, and the award criteria were different for each buyer. So here you can see the lots that form our markets and the different holders. Just so you notice, the lot 2 was cancelled, but this was the RaDAR market. So the overall situation of the RaDAR contracts. We had 9 lots and 6 different holders, which include large companies, small and medium enterprises, and startups. In these markets, we have 8 innovative solutions, ranging from rapid diagnostic tests, equipment to IT solutions, covering all hospital needs for tackling antimicrobial resistance. This RaDAR market is available at RaDAR for 4 years, so until 2028. So for this RaDAR market, suppliers can provide solutions to healthcare facilities through 2 distinct market access modalities, depending on the lots. Lots 1 to 7 are part of the intermediary mode. In this case, RaDAR only facilitates contact between the holder and the hospitals. The hospitals conclude the contract directly with the supplier. These lots are not eligible to subsidy. And then we have lot 8 to 10 that operate under the wholesale mode, and RaDAR purchase the Nosotech solutions and resell them to hospitals. For this lot, there is a 30% EU subsidy, which makes this market very attractive for hospitals, but also for companies. So only the wholesale modes could benefit from the subsidy. So now, for the results, for the intermediary lots, we have a total of 16 orders from 18 different hospitals. The lot 1, which is a global microbiology solution for equipment, we have 12 orders. And for the lot 3, a molecular biology robot, we have 4 orders. As antimicrobial resistance is not a budget priority in all hospitals, we are very happy with these results. So now I will do a little focus on the lot 8. So for this lot, we have 5 orders from University Hospital of Martinique, Marseille Public University Hospital Group, Roubaix Hospital Center, Intercommunal Hospital of Aix-en-Pertuis, and Le Havre Hospital Group. Also, Nosotech is in discussion with other hospitals, but they are more likely to place an order at the end of 2026. The subsidy will apply only to invoices issued and received before the end of the RaDAR project. as a result, for some hospitals, the subsidy will cover only certain items due to parcel invoicing. And so, as you can see, we have used almost 77% of the subsidy. I don't know if Laurent Belevance is online already.
Yes, I am.
So please, Laurent, if you can hear me, can you introduce us to Nosotech and more specifically to Nosocos, which is the lot 8, and to Antibiocos, which is the lot 10?
So hi, everyone, and thanks for inviting me here. Yeah, just a quick overview of where we stand in this overall, let's say, toolkits and solutions regarding the infection control surveillance software. So the solution that we offered in these two, in the three lots, actually, in the three offers, are essentially Nosocos and Antibiocos. The one that is now used in regarding this project is Nosocos, and we will eventually, we have discussions with those participating hospitals right now in the project, who will look eventually into Antibiocos. So Nosocos is the solution that is used by the infection control team, and the way it works is to connect to the hospital data through their different clinical systems, and then provide that in terms of intelligent dashboards and real-time tools for active surveillance of infection and documentation of infection cases. This then enables to have the full information from the different aspect of infection control to then be standardized and available for reporting, surveillance, and real-time review of patient and a day-to-day task. So as you can see, the main part here is definitely to manage the connectivity to the different clinical systems. This is modular, so it means that you don't necessarily have to connect to all of these different systems. But of course, the most important one is the patient information platform, which we call ADT for patient admission and movement. And then, of course, the lab, which gives us the added information to run the different alert algorithms and documents the cases. And then you can add other information coming from the pharmacy, of course, when you will add the surveillance of antimicrobials use. And then you can monitor surgery infections and other elements of the clinical system. Those systems will then connect to other data platforms, which means that you can have a almost automatic extraction of the data to then connect and report to national or regional surveillance platforms in whatever region you are. So our big, let's say, advantage or strength that we offer with Nosotech and these type of system is that we have a very good expertise and team managing the connectivity and standardization platform, which we have designed for in the last 10 to 15 years. We then connect to any type of system from any hospitals, whatever their clinical systems they are using. So it's really customized and flexible in terms of how we do connect, so that this is a big advantage. So this is the global view of the platform, and this is what is being used regarding Nosocos to currently the different hospitals that are that Ines has presented earlier, and which we are looking now to implement. In fact, yes, in other coming in the next month. Thank you, Ines.
So about the change management, we wanted to gather feedback from all project participants, both internal and external. To gather this feedback, we either held one-on-one meetings or we sent out questionnaire offering to discuss these results if necessary. The discussion was very open among all partners. Even so, we are a purchasing group. We wanted to be very close to the field, and this was a change management in our internal process. Another change management is it's that we have put in place some process that is the follow-up of this kind of projects with a pluridisciplinary team and the coordination by a project team. So for the feedbacks from hospitals, I will focus solely on the feedback collected from hospitals regarding lot 8, because it's a Nosotech lot. So with Roubaix Hospital, which was the first to buy the Nosotech solution, we had time to have several exchanges via online meetings. They are overall very satisfied with the solution and the support from the Nosotech team. Their only concern was the need to allocate man-hours for the implementations. Hospitals in Martinique and Aix purchased the solutions more recently and have not time to implement it. We still wanted to hear their feedbacks on the purchase and acquisitions, so we send them the questionnaires and not organize an online meeting. The University Hospital of Martinique highlights the quality of the project methodology implemented by RESA and Nosotech for the rollout of the Nosocos solutions. So as you can see, there is a global satisfaction of the hospitals about lot aids, good communication and support, effectiveness of the operational governance, and an appreciated centralized tools. So, Laurent, now we want to hear your feedbacks in direct live. So my first question is, how did you hear about the market and what motivated you to apply?
We were aware of the project a little late in the process, since we came in like in early 2024, being approached when we had the opportunity to be aware of the solution and having those discussions with RESA that explained the project and how it will go. So at this point for us, it was clear that this was a project that we needed to go in and apply and go in the process for the tender and have a bid for the, to make sure that Nosotech was there. We quickly realized the importance of being there, since we already were present in Europe, in France mostly, and already understanding how it's difficult to be able to have those solutions implemented in hospitals. So that the RESA RaDAR project was definitely targeting those elements.
You encounter any difficulties in responding to a French call for tenders? And do you have good practice to share regarding the process and relationship with hospitals?
Of course, yeah, it's still a challenge. Difficulties at first, well, like I've said, in the process itself and having Nosotech involved in the bid, we're used to answer to bids and different types of project like that. So our team was able to answer and apply, and I think that the process in itself went pretty well. In terms of relation and decision making with the hospitals, this is really where I think the most important, I would say, difficulties, but are still there. Even though, of course, the fact that we have RESA RaDAR is a very important advantage. Issues with hospitals are still related to decision making and prioritizing those projects in hospitals, because even when you look at the fact that there is a subsidy, having the infection control team being able to have their project prioritized within the overall IT projects in the hospitals, it's still a challenge for them. We provide very good documentation about how to bring those projects up in the priority list with them, but still it's tough. They have lots of IT projects in hospitals. We are in a period where there's a lot of let's say IT focus to have modernization in hospitals. So you compete with other projects. So that makes it hard for them. So they need to build a business case again to have that prioritized. So this is, I would say, the most important difficulty. And then when you have your project decided and going to the acquisition through the RESA RaDAR process and with the RESA, what is really, really important still is to make sure that you have a champion with your infection control team, but with the IT team in the hospital that is fully engaged and committed to this project to make sure that things will go smoothly. And I would say that in the case of Roubaix, where we are talking about, this was a good example of how the project went, and that went really, really smooth and efficient. And now, of course, they have a year of implementation, which we have now starting to evaluate the data with them. I would say that's pretty much those elements that are really important. In terms of, let's say, learnings that we have and related to that, I would say that really sums it in terms of how we should hospitals approach the project. It's definitely first to have a good, let's say, business case, but they need to have that as a priority, and having the right people inside the hospitals and of course in the IT team to really engage with them and make sure that they have the right project manager and experts that are involved in the project. When we have that type of let's say of team in place and experts, we can definitely run a very smooth project. And in our case, Nosotech takes care of most of the aspect of configuration, but we still have, of course, the requirement. We need to have a collaboration, and so this is why it's really, really important. And I would say that this is summarized. I would say the recommendation, or let's say lessons learned in the project. Yeah.
Okay, thank you. And last question, did the market meet your expectation? And what was the benefits of this contract for you?
Mm-hmm. I think I kind of touched it, but I would say definitely that it met our expectations. You showed the results. Being able to have these hospitals and many more right now, which we are in discussions, being able to have that as in that time frame, it shows that it has a huge impact. The RaDAR, with of course with the subsidy, but not only the subsidy, the fact that they can go and acquire the systems without having to go to a full tender process. I would say this almost has more impact than the subsidy at some point. Well, we think that will be it. So the impact of that is that we were able to have definitely more hospitals listening to those opportunities and having a discussion with us. Since they knew that they had the capacity to go into this project more quickly, then they were engaged with us to go into these discussions, and it has had a big impact. And we have more projects now that we think will go in. So it is a very important impact, and we are very, very satisfied with the result. And we know that there is more coming in front of us, definitely.
So can you develop now the main task to implement this kind of projects?
Yeah, sure. Those are the main elements that you see here. So project initialization at first, and like you can see, yeah, there is a complexity related to initiate a project, and that part is can be more efficient if, as I said earlier, we have the right persons, the right people from the hospital involved right at the first steps. So having a very good project manager and an IT leader with the infection control team is the key here. So it can go from very efficient, like Roubaix is definitely a good example, have very, very efficient project, to more complex project that then actually can take very long to start and initiate, depending definitely on the people we have on in the project at first with the hospital. So this is where we need to identify what connectivity we need to do, and the feasibility, initial, let's say, feasibility, having the confirmation that the laboratory systems and other clinical systems have the capacity to send the data, and that we have time to analyze those data and how the connectivity will be managed. So it relies a lot on people that are involved in this at this part. But once it's done, then we take charge and we manage the rest pretty efficiently. Then this is where we go into connectivity and data configuration. Our process involves that we do that for each hospital as on a case by case and custom base to make sure that we can connect to every type of system. And we standardize the data that we receive from each system to a central database that is used by Nosocus or Intibiocus. This is this is where we do the semantic integration and standardization also, so that whatever the data we receive, we standardize it to international lab or clinical data definitions. And this is the process that is managed by Nosotech. So at that moment, the hospital doesn't have to manage anything on this. This is where we take charge. And then we have the training. So we have like a week. This is 2 or 3 days on site that we do. We have our professionals going to the hospital, making sure that we, of course, we have prepared that before, because we have prepared the software, customize everything for the team, configure alerts, reports, and users, use case to prepare for the training. And at the training, they get on really take charge of the system. We have identified a champion, a pilot that will then on the hospital be the one who will lead the project with the users. 2 to 3 days maximum, and then they are fully live with the system, and then they are autonomous with it. And then we follow up. So post implementation is an ongoing process with them that is part of the of our services and that we have with our customers. That is very important because, of course, we go on, we add more type of surveillance, more type of alerts, more the type of data that they can manage. So we help them in the configuration of that they can do on their side, and making sure that everything is adapted to their situation, which is, of course, a key element. It has to be managed and planned before. But when you go on with the software, there are sometimes some adaptation or customization that would be required to make sure that there is fully, let's say, implemented and we get maximum usage in the hospital. But this is part of the process that we do each time. And then we can, of course, follow up with added training when required. But mostly in all of our project, the initial training, because we think we have solutions that are really kind of a that's a user-friendly approach. So they're really quick at taking charge and manage the solution.
Yes, thank you. I will try to go quick on the lessons learned and the good practice from RESA. So we improved our coordination and change adoptions. We have stronger financial control through formalized subsidy process, and we have expertise in PPI now. We also learned that implementing such a solutions requires a dedicated project team, available staff, adequate technical resources, and a strong IT team. For example, for Roubaix hospitals, it took several people and 3 months to connect the flow between the solution and the institution's equipment. And this time frame must be considered in the project. And the application portfolio of small establishments may not be sufficiently mature, and because the solution requires strong analytical skills. So, Laurent, if you can develop maybe quickly the lessons learned.
Yeah, well, I'll go quick. I think that you touched it also. So, in this lessons learned, good practice, I would say that connectivity. If you can, I don't know if you can keep the slides up there so that I can follow up. I can see if I can actually see the slides also at the same time. Thank you very much. I would make sure that communication with the experts and the lab team is very, very important. So that's why I said that we need a champion from the IT and the clinical systems right out to start, so that we can manage that right first at the project, and then our team takes charge there. Training and go live is really important. So if we have the strong expert in the team that can lead that with the infection control team, and having a power user identified, this is really, really important. So that's all of the start of project that needs to be identified. I talked about having an IT leader as much as having the lab expert, of course, in the project. And I'd say that we align early on the KPI also is important. Now we have kind of learned about that now. I think that for the next project, it's going to be easier that we have now an alignment of that, but you need to make sure that the hospitals are fully in right at the start to check if, they have these KPIs to be measured, what, they want to track it. In each case, it can be a little bit different, but you have to have some type of standard approval on KPIs. Thank you.
And then to conclude, there was a large adoption of this radar market. 23 hospitals have benefited from the call for tenders. The fact that we are a central purchasing body and that we propose this contract at the multiplayer effect, it is this model that have allowed us to have these results. PPI helps a central purchasing body to promote the procurement of innovation by hospitals. PPI also helps to promote innovative solutions across a large networks of organizations. We just submit a new PPI on the topic of improving integrated care in the mental health field. We are currently working on a new PPI to submit. The expertise gained through the RaDAR project allow us to apply to this other PPI. Thank you.
We are running a bit late, so no time for questions. If anything, we can discuss with Ines later at the lunch. And thanks also, Lauren, from joining from online and sharing your experiences. Now is the moment for BioGipuzkoa, that they are a health research institute, and they will also explain their role at RaDAR and the solution. So we have here Maider Santorquato from BioGipuzkoa, and online Luis Crespo from Qualut that will explain their procurement. And
so hello everyone, and thank you for coming today. Also for those who are joining online. As Maria said before, my name is Maider Santorquato and I'm from BioGipuzkoa, and together with Luis Crespo from Qualut, we are going to share with you the results that we have obtained during the project. So, well, first of all, for those that you don't know BioGipuzkoa, BioGipuzkoa is a health research institute located in San Sebastián in the north of Spain. So we boost translational health research, and we cover all the research and innovation carried out in the Gipuzkoa territory in the Basque Health Service called Osakidetza. So just a few organizational structure for our entity. It has three main areas or three main pillars. The research groups itself that they carry out research on different areas, the scientific technological platforms, and the support unit. I come from the innovation support unit, as you can see in the slide, and I would like to mention that for us in BioGipuzkoa, the RaDAR-PPI project it has been the first experience in PPI projects. So we have learned a lot in this experience since the beginning of the project. And also, I would like to mention that our participation in the RaDAR project has changed a little bit since the beginning, because in 2022, we started joining as a supporting entity in the consortium, but from October 2024 on, we are joining the buyers group. So we are the last buyers of the consortium. And as I will tell later, we joined the RaDAR's buyers group to purchase the RaDAR digital evaluation platform. So, well, the purpose of our contract, as I said before, we were the last ones. So one of the objectives of this contract was to gather all the solutions that the rest of the RaDAR buyers had. So we purchased a development of a digital tool that we called the RaDAR Evaluation Digital Platform. And the aim was the collection, analysis, and visualization of indicators and data for the evaluation of the purchased solutions by the rest of the buyers in the consortium, and also for the project or the RaDAR project as a whole. So we launched the tender on May 2025, and the awarded company was Qualut. So later we will have the opportunity to speak with Luis Crespo from Qualut, and he will show us the results of this contract. Before showing you the result or the platform, I would like to mention the theory of change that Maria mentioned before in the first presentation of the day. As she was telling, we all have the same objective, or the impact of all the expected impact of all the purchasing results is the same, but in our case, our solution is focused just on one of the activities that were defined in the project. So as you can see in the below part of the slide, our solution responds to the activity called structured data collection, assessment, and visualization. So having this into account, this is what we asked in our tender. So from BioGipuzkoa, we defined it and identified some needs that the consortium had, and we asked for a digital platform that respond to those needs. So, well, this digital platform, the idea or the objective is to gather data from different data sources, of course, from the clinical sites, from the RaDaR buyers, but also from other public databases, to have an acquisition model, on the one hand automatical, and on the other hand manual one via data entry with several templates. And then once the platform has this data, to be able to exploit and analyze this data in the 4 areas that Maria mentioned before, for the patient, sample, pathogen, and prescription management. Finally, for having an impact assessment or evaluation, as I said before, not only for the RaDaR project, but also for each one of the solution that the rest of the buyers procured. So in terms of our contract with Qualut, it was signed on June 2025, so just one year ago. So we had 1 year, 12-month execution with the collaboration with Qualut. As you can see in the slide, our contract was divided in 2 phases. The first phase was the design and the development of this platform, and a second phase for the deployment and the implementation of the platform. For several reasons that we will present later, these phases had suffered slight variations. So the design and development phase has been longer, until 10 months, and we have just 2 months for the deployment and the implementation of the platform. But well, nowadays the platform is useful for the consortium, and we are uploading the data to the platform and visualizing it there. So before giving the floor to Luis, I would like to mention some of the barriers or difficulties that we have seen during the project. As I said before, we learned a lot during the several phases of the project, but in the development of the platform, we saw well, this difference in 2 phases of the contract were slightly changed because of the delayed solution implementation also in the other buyers, not only in our case that we were the last ones procuring the solution, but also in the delay of the implementation of the rest of the solutions. Then it was quite difficult to have a common data structure because at the beginning of the project there were common KPIs defined for all the buyers, but as the solutions procured by all the buyers were slightly different, or each one has its different needs, the data structure has been well personalized to each one of the cases. So, well, this has limited the development time because we had to change some of the ideas that we have initially. But well, as I said before, we have the platform useful now, but I want to mention that we have some features or functionalities of the platform that we defined in the tenders. For example, the implementation of artificial intelligence tools for data analysis that have not been implemented in the platform. But also I would like to mention that the platform is prepared for that, and when we add more and more data, the platform will learn and will have these functionalities that I said. So now I think that Luis, you are connected online.
Yes. Okay. Thank you. Thank you very much. Well, first of all, thanks the consortium and thanks Aquas and BioGipuzkoa for giving us the space to explain our our solution in the RaDAR project. With me, there are Laura and Claudia, which are members of the team that were involved in the design and development of the digital solution and the platform. For those who don't know us yet, we are Qualut, and we are a digital innovation company specialized in healthcare. And our main area of expertise is the design and development of solutions, especially in hospitals, both public and private. And our main goal is to give digital solutions to real problems that have a great impact or potential impact in healthcare for hospitals, professionals, and mostly patients. Now, our involvement in the RaDAR consortium is the design of a digital platform that is built to centralize, validate, and visualize antimicrobial resistant data across multiple research entities. In this case, the entities that provided data are UNINA, ICO, Hospital de Referencia, and RESA. And well, the main goal is to replace fragmented and manual workflows with a single governance system. Now, it's from structured data ingestion to an interactive analytics and AI-powered report generation. I'm going to share the screen so you can see the platform right now. Now, please confirm me if you are seeing the screen.
Yes.
Okay. Well, first of all, what we're going to show you is the core flows of the platform. First of all is the authentication and role-based access, which is governed by a 3-tier role model, which would be super admin, super viewer, and viewer. Each role maps to a specific entity and defines what data the user can see, upload, or manage. Now, this isn't just a permission layer. It directly shapes what appears on the dashboard and what the AI reporting assistant can generate. Security is enforced at the API level, GWT tokens, 10-minute recovery codes, automatic lockout after 3 failed attempts, and session-limited access. The role boundary is also enforced at the AI layer, and the model cannot retrieve data or describe data outside the user's authorized scope. Now we're going to see the main modules of the platform. Okay. As I was saying, the main dashboard gives a full view of outcomes, results, and KPIs per entity. Follow the hierarchy established of outcome, result, KPI, and selecting any KPI opens an interactive time series chart filterable by month. Now with the thanks Hospital de Referencia, because they are letting show the data they provided to us. If we take this KPI, we can see the chart, which is filtered by month and year. And also these thresholds and reference values are dynamically managed right now from the database, but the platform is prepared for the future. Each entity can configure their own benchmarks, and the system highlights deviations in context, which means it's prepared to fully adapt without redeployments required. All this data that you see here is right now manually ingested through this functionality. As we can see from the administrator role, we can ingest to all the entities, but each one can only ingest data to its own entity. And right now it's a manual process, but as Maida said before, the first goal was to make this process automatically, since there were some delays in the data structure provided from the buyers and the standardization of this data. We made it manual, but it's prepared to be fully interoperable through APIs, RedCap, of any kind of structure in any kind of system, if it's either a pull or push integration through the API of the platform. But right now it's a manual process, and this data ingestion is right now only accepting Excels. and every upload is logged and auto-generated, title, entity, and timestamp. We can see here in this history chart. And as we can see here, full contents of any load are accessible via the detailed view. So we can always check when it's been loaded into the system, and deleting the latest load automatically reverts the dashboard to the previous one. As I said, is a dynamic dashboard. And this is a complete audit trail of the data lifecycle, aligned with the GDPR requirements, and since we're working in healthcare, with the MDR and IVDR regulation standards. As we were saying, this data ingestion also, to prevent fragmented data, has a two-layer validation, structural, from schema, row, and column count, and then content, times, formats, allowed values, to control fragmented data and allow standardization of the data ingested in the system. As I said, right now it only has this two-layer validation, but it can adapt to any kind of validation needed for any entity or future developments or future kind of data. All this process ends in what would be the dynamic report export that is managed right now through the AI chatbot that we implemented. As I said before, and as I might have said, the idea was that this chatbot could help the professionals to correlate all the information that this data showed, and also giving the professionals projections, patterns, deviations. But since the data structure and all this content, it's not been provided to us right now, what it offers is a description and a tracking of all the data ingested. But as I said before, the model we created is prepared through training and through data key points like vital thresholds, points of significativity, and all kinds of key components. It can reach the full goal that was intended at the beginning of the project. But right now, the function is this conversational AI that is a conversational interface embedded in the platform's back office. And right now, the users, as we're going to see right now, it describes what you want to see. Okay, and what we're thinking is the system prompt that right now it's checking. First, it needs to locate the entity. Then when you confirm, and always needs a confirmation, it's cross-checking in all the database the list of KPIs that you can freely select or just copy-paste through the code or the name. The system always doubles check, and right now we're focusing only in one entity, but the system is prepared to generate reports of multiple entities, as we're going to see later. As we see, the final step is to delimit the time period. We adjusted the chatbot so that you can choose a specific time period, or if you want to see the tracking of all the loads, you just can say no period, and the report will generate all the evolution of any data of any KPI. And right now, the first year that the system contemplates is 2025. But as I said, the system is prepared to adjust this filter to previous data, and that could be used for this correlation process and this feedback of more scientific or research quality that any entity or the project requires. I'm going to pick this one. the selection of the date period, you can just put any month you like. The system will automatically pick the first day of the first month and the last day of the last month, and you say confirm. It will generate the report. Yes. There we go. This is an example of the report, and it lists as a summary all the data of that KPI, that specific KPI, and the graphic of all the batches and variables of interest. This description was meant to be of more qualitative kind, but of course, it just now launches a description of the evolution of the data. Of course, we can train the model for giving more detailed descriptions and more specific descriptions. And if any entity in the future needs it, we can even put the addition functionality in this report so that you can add any kind of information before the PDF is generated. And as I said before, this is just one entity, but I have here an example of a multi-entity that you can see. In this case, we chose LRC, as you can see here. First, it takes one entity and then goes to the next. And the explanation for this is because the data structures at the beginning we thought would be the same, but since they are different now, it just separates them. But as I said before, we also plan ahead, and the platform is prepared, if it's in the future, give a comparative chart or a comparative report if any entity of the project needs it. I don't know if you want technical specifications on the AI chatbot, but feel free to ask our team. Since we are delayed for what I've seen when I joined the meeting, I think I'm going to be very brief. But with this set of functionalities, what we did is accomplish the main goals that might have explained before, which is the centralization of data provided by the research of the 4 different buyers, and also creating a digital space that can prevent data fragmentation, that can prevent any kind of data non-standardized security protocols, traceability, and the implementation of an AI models, that with the potential of scalability and future integrations with any kind of entity if it's needed.
So after showing you the platform as a result that we have obtained with this contract execution, well, we have just 1 month until we finish the contract with Qualut. So for these last weeks, we have some next steps in mind. We will jointly explore the platform continuity, because we really think that the platform can be used for, can have other uses. We also think that with some small adaptations, this platform will also be used, or can be used for other PPI projects. And as Luis said, and as I said before, as we have a really tight time for the deployment of the platform, we just have a few data in the platform. But during these final weeks, when the buyers can upload more data, we will also see more results. And finally, well, we would like to use also this platform for the follow-up and for the monitoring of the PPI procured solutions in RaDaR, and also the RaDaR project as a whole, and also in the future for other uses. So thank you very much. This was everything from our side. If you have any question, you have our contacts. And also you have now Luis and the Qualut team online, so we are here to answer, and thank you very much.
Sorry, is there any question for Maider or Luis online? No. Thank you. So thanks, Maider. Thanks, Luis, also for joining online and showing the platform and all the details on what it can, what is available to do, and also like what it will be able to do in the future if we feed it with more information and for even future PPIs. So now it's time for another break. It's time for lunch. Some sandwiches and quiches are prepared just outside. So please stand up and go ahead and have some food. Thanks for being here. Sí, sí, jo feia així, aleshores ja canvia. Sí. Hello everyone, it's time to restart. Maybe to grab the last coffee and we will continue now. Thank you. Thank you. Well, we will restart the meeting. This afternoon we have two sessions, one more focused on AMR, so it's called the Future of AMR Management, Insights from RaDaR and Beyond, and a second session that is more on the PPI, that we call it Value-Based Cross-Border Collaborative Public Procurement of Innovation, driving health system transformation. The idea is to have two sessions of the main blocks or the main important blocks of the project, that is AMR and PPI. So we'll start with AMR with Luis Locena, that is a project manager at INSERM, and he will give a presentation on the One Health perspective on AMR challenge. That is one of the deliverables that we mentioned before that was published recently. So he will go through the key results, and then we will have a round table. I will introduce you later. Thanks, Luis, and thanks for being back.
We work in several AMR projects at national and European level through a One Health approach. So we wanted to see the potential of the usage of public procurement of innovation to tackle AMR through a One Health approach. And well, let's say that I'm also working with Marie-Cécile Ploy and Olivier Barrot, but they were not here today. So this deliverable has four main content, and one is the review. Sorry. Yeah. So the first part is the review of EU health innovation strategies and public procurement regulations. Then is a review of PPI practices in the field of AMR, a review of AMR innovation in the animal and environmental fields, and a survey on animal health and AMR innovation. So we made an analysis of the EU health innovation strategies at European level, which are starting now, and it's actually very complex. And we wanted to look through the AMR relevance of these regulations and the One Health scope. And well, let's say that looking at all these sectors, the innovation landscape is very limited in the animal and the environment, especially when it comes to vaccines, diagnostics, waste management tools, and alternatives to antimicrobials. And there is a clear lack of a One Health regulatory framework, including the animal and environmental sectors. We also saw that there's a lack of green public procurement criteria for pharmaceuticals and diagnostics. So that means that some countries are taking the initiative to apply green criteria when procuring pharmaceuticals, but this is not standardized across countries. And when it comes to diagnostics, some of these criteria are applied to diagnostics that consume a lot of energy, but this is not across the board for in vitro diagnostics. And there are new benchmarking results for innovation across countries, but this is very general when it comes to health, and they are not specific for AMR. So we will give finally, after this deliverable, some recommendations to do benchmarking for AMR innovation. So the second part is about the PPI practices. In the field of AMR, we narrowed down to the European landscape and the RaDAR countries, and we had a look at the European portal, and we had a search through different keywords related to AMR. And, well, we prioritize here the three sectors, the human, the animal, and the environment. And most of what we have seen is in the human sector. And here in yellow, you can see that, well, we highlighted the ones that are more innovative when it comes to diagnostics and therapeutics and pandemic preparedness. And, for example, the ones that stand out most are the ones developed by DG HERA on the development of a rapid point-of-care antimicrobial susceptibility diagnostic medical device, and also metagenomic sequencing. And also was done through the JAMBRI, so the procurement of a new antibiotic in the European Union. But most of these PPI practices are based on training and capacity building and analytical and consultancy services. There are also PPI practices in the field of surveillance when it comes to whole genome sequencing of pathogenic microorganisms. For example, Acinetobacter and Enterobacteria, and tuberculosis as well. So there is more than this. This is already published in a deliverable that will be circulated soon. So you can have a look at the deliverable to have a more in-depth view. And then in the animal and agri-food sectors, there were some PPI practices observed, but not in the sense of PCP or PPI as we understand in this project. Most of them are also training and surveillance activities for EU agencies like EFSA, and also training methods for veterinarians and farmers. And when it comes to the environment, we found very little. So basically, it doesn't mean that there's nothing, but in the sense of the usage of public procurement, there's more room to do, to work on this. And we found a European survey on agricultural soils that's conducted by the Joint Research Center, where they analyze soil samples in agricultural soils for AMR and other pollutants of emerging concern. We also looked at the same in France, and there's a national portal, and we did a similar search with different keywords and the whole historic. And we found that most of these practices are in the human sector, and the animal and environment are not so well represented, and we also didn't find many, did not find practices on PPI as such, probably because countries are not in a situation to provide with funding to develop therapeutics or diagnostics on their own, and probably they will need EU funding, but that's my impression. And well, most of these practices are based on antimicrobial procurement and diagnostics, and also information management systems like software. and also construction and rehabilitation of research institutions. And we have a breakdown of treatments and diagnostics and also information management systems. For the first one is basically about procurement of automated diagnostic systems, antimicrobials, mass spectrometry, and sequencing platforms for hospitals, and some rapid tests. And for the information management systems, most of them are on vaccine monitoring and nosocomial infection monitoring. And then we also had a look at Spain and Italy, and we didn't succeed. We didn't have the capacity to do an in-depth analysis on this. But let's say that in Spain, there's two main barriers, an IT barrier and a territorial barrier. The IT barrier is that, well, there's no API in Spain, so you need to basically install a program in your laptop and upload many data files. And only then, if you look by some procurement values, you will be able to look at all this data. But the territorial barrier is that all this data is only available for certain regions and not for the whole Spain. So it was not possible in this project to look at this analysis in the whole Spain. And then for Italy, we did not find a territorial barrier, but indeed there is also a main IT barrier. So there is a consultation portal where you can look at procurements, but you cannot download the data from there. And then from the Agency for Digital Italy, there is an API, but you need a lot of IT resources that we don't have in our team. So I don't think it's impossible, but you need a lot of programming skills and work with large databases to do this, because it's not easy for the citizen to do a search by keywords and analyze the data. So apart from this, we also did an EU survey on animal health and AMR innovation, and it ran from November last year to now. And we wanted to see what innovation research needs are there for animal health. And while the survey is still running, the results have to still be analyzed and published. And this has been in collaboration with industry stakeholders and the Drug Spanish Agency. So if you scan the QR code, you can have a look at the questionnaire. And regarding the dissemination of the deliverable, the survey and the policy brief, we made a huge chunk of work in identifying all these stakeholders, basically procurement networks, policymakers, research funders, EU agencies, industry, and so on, through all these sectors. And this work has been disseminated also, or is being disseminated in different scientific events. For the part on the review of AMR innovation needs, we looked at global action plans and research agendas. And for the global action plans, we had a look at international and EU bodies. But most of these parties, for the global action plans, they publish basically operational activities that are not focused on research needs. So it did not provide much value for this search. So most of the results come from this analysis on the AMR research agendas, which are published by the One Health AMR Partnership, the Quadripartite, the Partnership on Animal Health and Welfare, and then other EU agencies. And these are mainly working on water and soil, but there is not much on the air compartment. So we identified a series of common and specific needs across all these sectors. And we basically made a distinction between material and immaterial innovation when it comes to goods and services. And yeah, there's diagnostics, therapeutics, or detection and treatment methods, and vaccines, alternatives to antimicrobials, and data management technologies. But of course, there's also room for the usage of PPI for operational activities such as training, dissemination, stewardship, IPC, surveillance, and access to therapeutics and diagnostics. And it would have been great to have time and resources to look at the business cases and the scalability of all these solutions, but we only had a review of the strategies behind this. So this is just a glimpse. If you want to know more, you can have a look at the deliverable that it's being circulated now. But most of the AMR research priorities identified are in food-producing animals, not so much in the companion animals or wildlife. And then in the agri-food and food safety, there's also quite a number of priorities identified. So basically all of these tackle vaccines, alternatives to antimicrobials, the exploitation of the phytobiome and the soil microbiome, genetic breeding for animals and plants, and integrated pest management strategies, AI technologies, and wastewater and sludge treatment for crop irrigation and fertilization. And regarding the environment, most of the research priorities are on the wastewater sector, basically chemical and biological threat detection in water discharges and wastewater, and also the application of nature-based solutions. And for soil, there's not much evidence yet, so still working on it from the research side, but there are applications on the usage of nuclear techniques for the determination of antibiotic residues, biotransformation pathways, and their usage to monitor what is the pollution in agricultural soils for this, and also the AMR bacteria through metagenomics and sequencing. And last, well, let's say that we had a dissemination campaign in 2024 on AMR. This has been in collaboration with the EU JAMRAI, which is the project I work on. And you will see here that we created this AMR awareness symbol, which is 2 pills, 2 antibiotics put together. And you can use it. So the main idea behind this is so that people can increase their awareness about AMR and do a similar thing as they did with the HIV ribbon or the breast cancer ribbon. So yeah, I think that's it from me. Thank you. I don't know if we are on time. Yeah.
Thanks, Luis. Yes, thank you. No problem. Thanks a lot for the presentation and for the overview on the deliverable. Very also interesting findings. So now we will move to the roundtable. Luis is actually going to moderate the roundtable as well. And then we ask the participants to come here. And they are Assumpta Ricard, that is the Healthcare Planning Director of CatSalut, Madalena Hilario from UNINA, the Associate Professor from the Department of Public Health, and Bonaventura Ruiz, that is the Director of Laboratorio de Referencia. So thanks a lot for joining us. And yeah.
Can you hear me now?
Yes.
Okay.
Yes, I think you need to activate them. Yeah. But everyone has.
When you speak.
When you speak, yeah.
Sorry. So thank you, everyone. We have a nice panel session with a wonderful round of panelists here. So I have here on my left Assumpta Ricard, who is the director of the Catalan healthcare system. And then we have Madalena Hilario and Bonaventura Ruiz, that you know already. So I wanted to start this panel by asking Assumpta, what are the regional health plans to bring forward AMR innovation in your region, in your institution?
Thank you. Can you hear me, or I have to put this one? Yes? Is it okay like this? No? So, maybe I'd have to put it... it's, well, not very old, but... pardon? No, it's open. It's green. It's open. That's all we can have. Yes? Is it? Okay, so great. Well, first in Catalonia we are fortunate because we have healthcare professionals not only delivering care, but they are really good and they are very strong in innovation mindset. So in fact, from the administration point of view, it's quite overwhelming because they are producing and they have a lot of ideas. And really the great challenge is how we introduce this into our health system, how we make that all this innovation gets the patient, reaches the patient. So in that sense, we are quite proud because we are making real progress in bringing all the key players together, key players that can channel all this innovation to the patient. And so this is our agency of quality and assessment, our health department strategy of innovation, the ICT Foundation, and of course the BioCat as a key driver for innovation ecosystem. So we really are together. In fact, I would say that we are friends, and that's very important because we can control all the innovation and try to get the system. So from the point of view of the Catalan Health Service, our instruments are governance, contracting, and of course incentives. And on this sense, first on governance, we are investing quite a lot of money on having a structure with 3 plans. First one is BINCAT, with its unified surveillance systems on infection related to the system. Then the PRAN, which is the Catalan Antimicrobial Prevention and Optimization Program, and then the PRAN, which is the program for antimicrobial resistance. This last one is not only for Catalonia, but is for the whole system. But so this is about governance, but about contracting and incentives. I would say that the most distinctive contribution that Catalan Health Service lies on how we use our purchasing and financing role. On this sense, even it's timid and we would like it to be bigger and bigger. We have a system of value-based contracting. So the Catalan Health Service receives all the money from the government. It's about 14 billion euros for healthcare. So Catalan Health Service transfers this money to the providers, and they do the job. They provide the care. So we do not prescribe. We do not buy equipment. So our instruments is the value-based contracting. So in the contract with our providers, 5% of this budget is at risk. So it's associated, is linked to the achievement of objectives. And in fact, talking specifically about antimicrobial resistance and the issue that we are talking today is that, for example, we have one of these objectives is mandatory surveillance. So it's obliged, of course, because if not, you will not receive this part of your contract. The second one is the program, the antimicrobial stewardship, and it means that these objectives are linked to antibiotic consumption, to resistant patterns, and one very important, which is targeted prescribing improvements. And then the third part of these objectives is infection prevention and patient safety. It means that we control and we pay or not pay, where they receive this 5% or not, depending on the infection-related, hospital infections related with the healthcare, not only hospital, but also in primary care, or surgical site infections. So this is a timid part of our value-based contracting, but it's 5% of a big amount of money. So these are the main governance, contracting, and incentives.
Okay, thank you. Yeah, I wanted to know as well, in this current geopolitical context and also the different challenges when it comes to definition of health and all the, the societal role of health and so what Is your institution adapting to this ever-changing environment? How are you, I don't know, with population services or specific patient groups?
I don't know if I understand. Could you please repeat the question?
So what is the, how are you adapting to the real future challenges of health from your institution?
Well, that's really, in fact, our system is, we adopt because our planification and, for example, our instrument is healthcare plans. Mm-hmm. And so through healthcare plans, politicians define which direction we take, and then the Catalan Health Service, which is the arm or operational arm of the health department, translates it into operational actions. So, for example, I reviewed our healthcare plans. Mm-hmm. In the last 3 ones, it means 12 years, and in the 3 of them for 12 years, antimicrobial antibiotics use and antimicrobial resistances, it's specifically in these plans. So I think that the most important thing is that always see that is not a clinical issue, but the most highest system level commitment. So starting with the healthcare plans, and then through contracting, and then through our providers do things, they perform the assistance. So it comes from up bottom, of course. So the strategy is directed by the health plans.
Do you also interact with other players like cities, patient groups, or?
Well, all our plans nowadays is unbelievably. We cannot all our plans or our planification. We have patients inside. All our expert groups always. Sometimes from the beginning, and sometimes with focus group, or sometimes after we have the plan, then we consult with them. But they are present in our planification. I think we cannot imagine any planification nowadays without the citizens in it. In fact, our healthcare department has a school of health that is addressed to citizens to improve the capacity to influence the system. Mm-hmm. Because what happens when we count with the citizens, they don't have the power or the way, or not. It's difficult for them to arrive to our strategy. So even though the health department takes care that they can improve their skills to present proposals to the system.
Is there any other thing from your institution that you want to highlight? Any lessons learned?
Well, maybe they can. It's all the time for me. So no, okay.
I think it's okay.
So maybe later.
Okay. Yeah. So my question for Madalena. So I know that you are not only working in the AMR field, you're also working in other public health areas. I would like to know that. What challenges are common between AMR and non-communicable diseases, and how these public health actors should work together?
This is a really interesting questions, because AMR shares with the chronic diseases patients the risk. So most of these patients have multimorbidity. They are affected by conditions that bring them inside and outside of the hospital many times. Like if you think of cancer patients, of diabetic patients, and these patients are exposed to procedures that are at risk of contamination. So probably the good way to go hand in hand would be trying to push antimicrobial resistance principles into the diagnostic therapeutic pathways for these patients. And if you think about non-communicable diseases in multimorbidity patients, in these cases you have polypharmacy. Polypharmacy itself can be a risk for drug-to-drug interactions, so there is a need to push for medication revision, the prescribing, and this could be helped if we would strengthen awareness of appropriate antibiotic prescription. So there are several points where they touch each other, and I think if they could at least identify some synergic objectives. They could reciprocally strengthen the improvement of overall health outcomes and sustainability even. Yeah.
Thank you, Madalena. I also wanted to ask you so about your contribution to the National Action Plan in Italy based on your work in RaDAR. And I know that from the European perspective, for example, there's been some advances when it comes to AMR plans to apply joint procurement and stockpiling of antimicrobials, also pre-commercial procurement for diagnostics. And also in Italy, you developed recently an incentive program for new antibiotics. So, yeah, what do you think? How do your work in RaDAR aligns with the strategy in Italy?
It's very well aligned because I think that the investment in new antimicrobial drugs is very important. We need it, but it's not the solution. It's one part of a solution that is more broadly represented by what we managed to integrate in RaDAR. We have a new plan to tackle antimicrobial resistance, the PNCAR in Italy, and what it looks for is reducing, strengthening interoperability and reducing silos between data, improving appropriateness of prescription of antibiotics, improving surveillance, and strengthening stewardship. So these elements were all included into the solution we have been implementing in RaDAR. Even if we didn't manage to achieve full deployment of all the potential of the solutions we purchased, there is a very broad opportunity to continue exploitation of RaDAR solutions to implement the national PNCAR in Italy. But there is one point that emerged during implementation in our settings, that is the human resources. So there is we need more nurses and more infectivologists and more microbiologists to really implement in the community, because the hospital are understaffed, but the implementation of the antimicrobial resistance plans in the community is even more challenging. So we will need to invest also in human resources, and there are gaps between Italian regions that should be addressed if we seriously want to achieve these objectives.
Okay. Thank you, Madalena. Very nice. And then we have Bonaventura. I would like to ask you about, so you have shown your solution in this project about the combination of rapid diagnostics and whole genome sequencing. How do you see this being feasible in the near future, and then the benefits and the barriers for this implementation?
Well, okay. I think now we are all convinced that AMR is really a problem to tackle. It's something urgent, and it is a thing that must be tackled by several actors. One is the health professionals, although in the laboratory or in the hospitals, and also by the in vitro diagnostics companies, also with IT companies, and well, it's a problem of different actors. There is also a problem too with the managers, and also as the level of a systemic management of the health system, because these solutions need resources and needs money. Okay. In our case, we joined the RaDAR in 2024, but there was previously a commitment and also a background in trying to afford or to apply to tackle this problem at Hospital del Mar in Laboratorio de Referencia Catalunya. So the PPI RaDAR acts as a catalyst to put or to translate this preparation, this background to reality. We have running this pilot during 8 months, and the results are quite promising. I don't know if spectacular results, but are quite promising, just to let know that there is a good basis to work with in the future. at what point are we in Hospital del Mar? Well, as Dr. Ricard said, the Catalan health system contracts services to the hospitals, and the hospitals have to receive money for these services. There is no special program to the vigilance or to tackle the problem of AMR. So it's something new, something that costs money, and I think the hospital at that time it's not easy to invest money in something that is new. So they are waiting, for example, I know Hospital del Mar and other hospitals that are really not in a good circumstances in the economic point of view. Always the healthcare is always very demanding of money, and new actions take times to be adopted in the hospital. So I think it's a very nice step and a productive step, but it needs time for a hospital, in this case for Hospital del Mar, to be adopted in the routine system. But the results are quite interesting, and it's a good basis to work with in the future. I don't know if I've answered your.
I would like to.
Sure.
I would like to mention part of what you said, because you said, well, Catalan Health Service is not investing specifically on antimicrobial resistance. They're struggling against antimicrobial resistances, but what costs the most is not to do anything. So Catalan Health Service contract services for you to do the job. So if you do it cheaper, the difference is for you. So the cost of infections due to multi-resistant infections are so huge at hospitals. In fact, the difference is of patients with or without nosocomial infections with non-susceptible, it's 33%, and the length of stay it's 27%, and mortality is 61%. So since we pay for performance, the activity, and you introduce these systems and you save money, you have more money to invest in yourself. Yeah. So I think this is a key point, that we don't expect from the system to put more money, but to respect the money and do it better, because the difference is for the provider. So I think that we have a large improvement area here. So.
I think there is.
Sorry.
There is always no. But there is always an initial. It's like an enzymatic reaction. Eh? You always need a initial burst, seen as the part of the hospital and the managing team in the hospital. It's not really a savings just in the moment zero. You need the time to do the initial investment, and that's why it's really a barrier. Yeah. I think.
In fact, the problem is that you save money, but maybe you save money next year, 2 years. But to initiate it, you need to push. You need this money. That's true. So, but it's a matter of efficacy, and this to try to avoid these infections is save money. But yes, and the other problem, especially in Catalonia, I don't know in other countries, but we don't really have a system with a good public-private collaboration. So we are very fond of public health, and of course I am, and I think all we share this. But at the end, if we are not confident, we don't establish a good relationship with public-private collaboration, this is not possible, because this money, you need to invest and to save money in the future. Sometimes it's the industry who has the money to put it on it. So maybe in our system, the public-private collaboration is not enough to adopt innovation, I think.
No, you can get it. So I had just one last question about I think it's the pharmacology unit of the Hospital del Mar, where you do like personalized AMR treatment. I don't know if you can share a little bit of this. of its innovative strategy in your hospital?
I guess you visit our laboratory
Yes.
and saw this unit and get quite impressed. No, it's just to mention, it's not directly directed with antimicrobial resistance, but it's indirectly. This is in Laboratorio Referencia Catalunya in collaboration with Hospital del Mar, and there is since I think 7, 8, 10 years ago, they were established a unit that does pharmacokinetics and pharmacodynamics of antibiotics and other molecules, just to test in vitro what are the efficacy of the antibiotics and to optimize doses in the patients. And they do this with a in vitro model that is called the hollow fiber. If you type in Google hollow fiber, there is a model that it was created 10 or 15 years ago, and it works very well in order to mimic in vitro and in very controlled conditions of biosecurity what it happens in the patient. And then you can adjust and monitor and optimize very well the doses of the antibiotics. It's quite particular.
Okay, very interesting, thank you. I don't know if we have time for more questions. Yeah. Okay, so we have some more general questions. Yeah, do you think that the solutions shown in this project are economically sustainable without EU funding support?
Well, I think I answer. What is not sustainable is not to do something because it costs a lot. So we have to think of the price of not doing, definitely.
Yeah, I agree. I think that we need to collect more data to show to politicians that the money spent in innovative solutions is worthy. So I know for a fact that we are already with this experimental approach reducing the days, the length of stay. So that then you can do the count, because if you have just counting the reduction of the length of stay, that is a case, that makes a case for sustainability. But then there are a number of direct, indirect cost, social cost, impact, and other things that you can pile up in the calculation that deserve a real cost study that we could do starting on the ground of the platform that we have been developing lately. So this is something that has to do. I would do an avoided cost study, very simply.
I would like to add a new question, that is that, well, in fact, illnesses doesn't work from 9 to 5. Illnesses are always there in a 24/7 day basis. And our healthcare systems are mainly based, and yet now working in this shift. Reasonably puts the necessity, for example, for the microbiology 24/7 in every hospital or every tertiary hospital here in the country, and of course everywhere. And this, of course, it translates in more amount of economic burden in the hospitals. But it's something that we have advanced to solve in the near future. Today, what the questions that it has to be a laboratory of analysis, biochemistry, and hematology 24/7, and I think we are demonstrating that it's the necessity in the microbiology also works like that, and also the other part of the lab, the clinicians, in order the results to be actionable. With actions, there have to be someone at the other end of the phone ready to make a decision on isolation or something like that. So it's complicated. It's not easy to translate these pilots to the reality, because they have associated a lot of cost and changes and tensions in the organization of the hospital. So it's a challenge for all of us.
But I think that Catalonia is very good shape, because what you are saying, that you are set for innovation, is very important. This means that you have, at least compared to other healthcare system, the use, the habit, the flexibility to adapt to the integration of a new solution, because otherwise there is a resistance to change that is especially due to the healthcare professionals, the nurses, that if they are not used to work in innovative environments, could make impossible the implementation.
Thank you for your words. Yes, we really are in the ecosystem that is open to change, and I think it's quite flexible. Anyway, the great challenge is how all this innovation is introduced in our public health systems, and in fact, nowadays is the main problem. We have a lot of solutions, but it's difficult for us to find how we introduce it, how we adopt it into our system. That's the main challenge.
May I ask you a question?
Yeah, sure.
If I may. So you mentioned performances. So do you acknowledge the involvement of healthcare professionals in innovation activities in the performances of the healthcare system? Do you acknowledge, so do you value in the performances the involvement in innovation?
Absolutely. We have several initiatives. In fact, one is BioCAD, and we have here also some representatives that we are making calls. We want to go from a reactive system, which people innovate, and they do a lot of things, and then we don't know where we are, and even some solutions, maybe we don't need them. So I always say that we have a lot of people with solutions that they are looking for problems, no? So we have a lot of, so we want to go from this reactive to a structured adoption of innovation, and how we do it through this putting all the players together and going for calls. For calls where from different points of view, Aquas, the Tixalo, the health department, we all accompany all these innovators to get to go to a good end. So I think from reactive system to proactive address to introduce innovation.
So I think this is a very important lesson for your colleagues in the other countries.
Oh, thank you. So we are just learning.
One last question I have is about, do you believe that Europe is creating the appropriate market conditions for the adoption of AMR innovation?
Say it again.
Do you believe that Europe is creating the appropriate market conditions for the adoption of AMR innovation? Or still far away?
No, we are not far away. I think we are in the middle. We are in the middle of the transformation, and there is a lot still to do, especially in the administrative part, because it's not. Whereas if you make a change, professionals in the healthcare system, in the university, they self-manage, adopt, study, and implement. In the administration, it's very straightforward, top-down, so you need to brainwash the director general to convince him to embrace innovation. Because I think administrative compartments is a silos, then they think that innovation is not related to them. It's something that concerns other people, so they are not involved. So I think this is something we should explain them, that if the society needs innovation, they are part of the players of the innovation, and it involves them. It's a responsibility they need to take, and they should take the responsibility to make an effort and implement innovative solutions. It's too easy to say, oh, I've never done it, I cannot do it, and someone else's responsibility. It's also the responsibility of the administration.
Just my part, just to say that I'm quite confident with companies of in vitro diagnostic sector. They are, if in Europe, in Europe, they make the conditions that they work and think and develop new kits and new strategies. They have a strong, the big companies and also the small and medium enterprises. They have the talent and also the will to advance in this project. So make them easy to work.
Yeah. Well, I really don't know the market. I would say that Europe is making efforts, and that is an example of how you can put together buyers in different countries, and it's RaDAR has demonstrated that it's possible to do it together. but it's really, really extremely complex. In fact, I wonder how RaDAR has been possible, because when we try it in our region, it's so difficult, and we are the same system and the same payment and financing models, and even in that, it's so difficult to put them together. So this is a real example. It's possible, and I hope that RaDAR leave us not only the results you have presented, but also a methodology that can be used in the future to promote these initiatives, because if not, RaDAR would have not been enough. So I hope so.
Thank you. I think this is a very optimistic way of finishing this roundtable. Thank you so much for being here.
Thank you. Thank you very much.
Thank you.
Thanks, Luis. Thanks to all the speakers for this roundtable. I sometimes also wonder how RaDAR was possible, but we made it. We made it possible. So now let's move to the PPI part. First, we have Rosanna Alessandrello, that is the Value-Based Procurement Director at Aquas, and she will give a presentation on the handbook that we prepared on the value-based cross-border collaborative public procurement of innovation. Rosanna, I will...
Thank you very much. And very interesting, very exciting, the table before, because also gives me some elements of discussion when I'm going to present these slides. This document for us is, we are really proud of this document. This document at the end of the day is a fruit of the collaboration of all RaDAR consortium, but is also a fruit of experience along several years of cross-border public procurement of innovation. But with RaDAR, I don't know now how to say it in English, we put la cereza encima del pastel. We did it, no? We did a step forward, and this is very good, and clearly, but by the way, that's also clear that this means that every time that we add difficulties and a challenge, we add something more additional to the methodology, and so this methodology is a live methodology. We cannot say that we have already learned everything about public procurement innovation. Every time is different. We are tackling with a different animal, and every time we learn something. So let's now go through what we learned this time. As already Maria explained, we are talking about coordinated procurement. So we had the mandate from European Commission to put together, to prepare, have a common preparatory phase among all the buyers. Although, as already also was highlighted during the roundtable, the Laboratorio di Referenza joined a bit with the support of Hospital del Mar and Consorzio Salute Sociale di Catalunya, joined a bit later. But still, our common preparatory phase was very aligned with their needs, so they could join very fast, I would say, and very proactively our project. And we had this phase of clinical demand definition and of open market consultation. With the idea already that then each of the buyers was going to launch their own tenders, and they were going to monitor their own contracts. It's important to say already that the clinical definition has some relevant steps that we suggest to follow, and we have learned to follow, somehow increase the success of the procurement definition. That is talking about the theory of change. It's true that already Maria was explaining already that somehow we were following the methodology on how we were identifying the needs, the common needs, but then when you need to look at how to make this transformation at your own home, the very best thing is to think about what is the transformation that this intervention will generate at my home. And as also Maria was already explaining, we do, starting from the impact that we want to generate, looking at if we want to generate this long-term impact, what are the mid-term results and outcomes that we should generate to enable the one day to contribute to the impact, what are the short-term outputs that for sure we generate in the contract that contribute to the mid-term outcomes and to the long-term impact. We look who we are, that is input. We are in hospital, we are in university hospital, we are in an oncological hospital, we are a GPO, we are a research institute, and we are a regional laboratory service with the support of a general hospital. And looking at who we are, we define the activities. And when we define the activities and when we define the results, already we should take into consideration the different stakeholders we are impacting with this intervention. First of all, the patients, then the professionals. Here, we are saying professionals. So professionals of the healthcare organization, not only healthcare professionals, as already was pointed out during the presentation of the buyers. The healthcare providers that are adopting such solution, and ops, and this is something very related with what we were looking at, what our panelists were talking about during the previous table, no? The healthcare system and the payer. Are we changing our relationship with the payer because such transformation? Well, most probably, as Assumpta was saying, no. So the business case is really looking at how we are being more efficient. The word efficient is maybe not so, it's partially true. That is, clearly we need to be more efficient, but maybe we need to look at the results, no? Again, from patient perspective, professional, and my own institution, in a way that when I get the money, no, for delivering such services, I can be sustainable. And this sustainability, yes, it's tied also, why not with efficiency, but maybe not also. Maybe it's a better patient experience. Maybe it's a better professional experience. If I spend the same amount of money, but the experience is improving, it's still something worth. And by the way, it was already said also in this table, sometimes to get the very first push, no, to get system innovation in place, we need maybe also an economic push and support. But then we need to know, to build a structure, financial viability to make it happen. And then there is another, so these processes are needs driven. And so everything is defined by the needs. But then we cannot forget the market. And so this second arrow is very important. And in fact, in RaDAR, also we're experiencing this, that if the market was not so clear with us, or we were not so clear with the market, or we were not so clear with each other, by the way, sometimes it happened to us or to Aquas and the innovation procurement we experienced already in the past several times, that there are things that are not said during the market consultation, then the call for tender is desert. And this is a bit failure, because we should know, no? We should talk before to understand really how much also the market wants to take the risk to make such a transformation. We should understand each other. And so we should try to avoid this. But still, we are not so capable sometimes. And by the way, rather we could recover it and we could make it. And so this is the theory of change of RaDAR that already Maria presented. And then this is a very nice also slide, very nice, because also we were mentioning about it indirectly in the previous round table. At the end of the day, each of innovation, if it comes from the bottom, and the response gives an answer to the needs of the healthcare provider, pass through the different phases, and maybe also comes from the health system and from the payers, but so it's not bottom up, it's top down, but still with the idea that we need to go through different stages up to the scale up in one health system. We have a research and development stage. This could be a pre-commercial procurement phase, or could be a research and innovation action, and where we go from the design of solution to proof of concept. Again, we are designing a solution and we are doing a proof of concept with needs in mind. Always this process are needs driven, are not technology driven. That's very important to have it in mind. It's not something that is not a technology push. And it's very important also that already we assign, we understand who are the first potential adopter of such technological research, once one day will be ready, and how we are going to evaluate such technology. Because if we already did the exercise before, impact, long term, mid term, and short term, clearly at this stage we will look at short term results, but already with in mind that this short term could contribute to the mid term, to the long term. So we are not looking at an HTA evaluation. We are not looking at something unrealistic, but still, but already maybe why not, if we need to do some trials, we could put some elements to start measure what one day in an HTA will ask us. And then if we are successful, then we could start to think about how to go to the implementation. So if to go to the implementation, we should have certified technology. If they are medical devices, if they are not, maybe they can be already commercialized. And we could start to measure the impact, these outcomes we want to generate, again, in 1, 2, 3 hospitals, with the idea that then maybe one day also, if is needed, because maybe the payer really is not needed in the in the equation, maybe can then one day evaluate it further for a scale up in the system. And then finally we go to level 3, because maybe we have escalated to one health system or two health system in Europe, and so we could go for, why not for now we have this joint, the new HTA regulation, and we have this joint assessment. Maybe we could go then with local, no clinical domains evaluations to other health systems. So it's important to know, to understand what to evaluate at each of the stages. And this was generated, this schema, for an evaluation of an action in cancer precision medicine called CAN-HIL. And we are now applying exactly this framework to the PASS, that is this accelerator that promoted by Department of Health, by Biocat, TIC Salute, and Aquas in Catalonia. And so we are supporting the technology providers that have the potentiality to address needs already identified by our health system, to go through this model. In the case of RaDAR, clearly we had the anti-superbugs exercise, it was the pre-commercial procurement, and now we have RaDAR, that is the public procurement of innovation. And then we have the business case. The business case is exactly the analysis of the values versus the risk that we can take versus the evidence that we need to generate, or it's already generated, and the readiness. The readiness is very important. That is the readiness not only of who is going to adopt no, this transformation, but also who is going to deliver the transformation. And today, in the morning, a couple of technology providers, a couple of solution providers were mentioning that maybe the hospital was not so ready, or we had to give a push to make it ready. And this is, we need to be honest with ourselves. Are we ready? And this, yes, and that is very important. And so every time that we go for a public procurement for innovation, we need to look at the value we want to generate, and if we need to take, because really there is nothing ready, neither from technology perspective, neither we know what is ready or not, because still everything is in prototyping, in research stage, we need to take a major risk. And this could be a pre-commercial procurement, like anti-superbugs. If we already have commercialized solutions, but they are supporting us to make a specific transformation, we need to go through this evidence generation. And this evidence generation is exactly what we are doing in RaDaR. So our sphere is a bit bigger, because the provider are more prepared, because more or less they know what they have, and but still they need to learn the transformation we want to do, and the same the healthcare providers. And once we are in the stage that everyone is ready, it means we have generated enough evidence to do a regular procurement. This is schema that was already presented by Maria. So all these aspects were introductory to this. And so when we talk about the needs stage, again, we need to think about the needs with all these impacted stakeholders in mind. And the rest already was introduced by Maria, so let's skip it. And then in RaDaR, together with other procurement that we were running in the same period, we implemented and we put in place this methodology to have contracts permeable to value. That is, all main elements of the call for tender, the object of the contract, the awarding criteria, how the contract is monitored and the payment schema is defined, how we define the bid, the template bid for the technical offer, and the expertise that we need to evaluate the bid and to monitor the contract takes into consideration the value that we want to generate for each of the impacted stakeholders. We put together an evaluation framework that not only evaluate the needs at the beginning, are real needs, what is the impact if we don't give like in a cost opportunity analysis, if we don't address them, it's this concept viable. And then we evaluated the final outcomes, outputs, the market, the contractors, the buyers, the economical operators, and the policymakers. And so somehow we did a continuous evaluation process from the beginning to the end. And then there is the last one, that is we put together with RaDaR, and this is a very nice additional step, a way to start to compare the different contracts. We identify different elements, the buyer, the health system level of transformation, the readiness of the adopter, so who is the adopter, the object of the contract, the needs and expected value, the risk and mitigation collaboration models that are mainly contractual, financial, technological, and IPRs and licenses, the value to measure, what we need, how we can generate the evidence, what we need to measure, the readiness of who brings the values, so somehow we could assess it through the open market consultation and through the applicable regulatory and the solvency of the economic operators, the readiness of the solution through the awarding criteria, and then elements like the contract file status, the contracted economic operator, and the measure results and generated evidence. Clearly, this is embryonic, but it's important because now we have like a structure to see with all different contracts what kind of information we are doing, because the contract is already defining the intervention and what are the achievements we can reach. That's all. Thank you.
Thank Rosanna for the nice talk and the nice presentation on all the process that we did at RaDaR as well. Now we will move to the roundtable about PPI. So it's called Scaling PPI, Opportunities for Health System and Industry. We have Igor Kalinik, the head of sector of ISMEA, as the moderator of this roundtable. So thanks for joining. And as the speakers, we have Berenice from RESA, Jordi Jordà from Consorci de Salut i Social de Catalunya, he's the Innovation Director, Mark van der Bulk, the Head of Service of the Belgian Cancer Center Scienziano, and Olman Elizondo, HIPS Project Manager and also Innovation Project Manager at Aquas. So the floor is yours, and thank you all.
Yeah, I love the, yes. So Bernice, Jordi, Olman, Mark. Okay. Igor, Kalinic. It's icy.
Shall we take the micro?
You have a lot of. Sorry. Oh, sorry. You have a lot of what's called football players. Come on. One of them. I cannot say the other one because, of course, it's from another city. Okay, welcome. Thank you very much for the invitation. Actually, I am head of sector of the sector that was managing this contract from the Commission side. I know that this morning my deputy Joanna was here. She opened this event. And what I heard earlier, yes, it's difficult, and was a very good answer. Was it? I think you replied. Was it worth? Well, if we don't do doing nothing, it's just too high the cost. This morning I was doing actually a lecture presentation, and it was about AI and the governance and the competitiveness of Europe and so on. Even there, we have an AI Act, if you might know. If we are the first one in the world of the major institutions that has produced something, and some people are criticizing, well, this, that, it's too vague, it's not. Yeah, but we are the first one that has done something. And we did that in 2021, I think. So even before ChatGPT was there. So now everyone in the United States, Australia, they are asking us and to see and to copying us and adapting to there. So there is a lot of work to be done there, but this is, I mean, talking about that because it is innovation and it is procurement of innovation. And when it comes to the procurement of innovation and the RaDaR project, one thing strikes me, there is a contradiction in terms. Procurement and innovation, right? We are procuring something, as also me as being a governmental organization, something that I really don't know. The first rule in the procurement is write the term of references as you know exactly what you need. Well, like it's still not invented, right? Or it's still not really adapted to what I need. So this is of course difficult in the end. And I think that is very important that we are trying to put actors together, and of course the simplification of the regular aspects goes together, and that we are very aware. But I will start with Bernice, and you were GPO, right? So it's a group purchasing organization in the processes in this in RaDaR, and based on this experience, what role a GPO like yours can play in future value-based procurements of innovations?
Thanks, Igor, for the great question, because it's a huge question, and I think we don't have enough of time to answer to this first question, but we have another one, so I will be quick. Building on our RaDaR experience, we think that CPBs, so central purchasing bodies, can play an ever stronger role in the future, in a future PPI project, by accelerating the scaling of innovation and by facilitating its adoption across healthcare systems. And this role can be explained and illustrated across 3 key dimensions. The first one, and the most important one, is our procurement expertise, because procurement is our core activity. We provide organization with access to product and services with the main objective of achieving the best purchasing conditions by pooling demand and services, thereby reducing costs. It's our mission, I would say. And in this context, RaDAR, so one of the most important French central purchasing body, offered tailored procurement solutions, covered a wide range of needs, because we propose products and services from medicines, medical devices, to intellectual property and consulting. So it's quite a large scale, I would say. And we offer these solutions to more than 4,200 beneficiaries, and within these beneficiaries we are hospitals and as well local authorities. So we have a lot of different profile of beneficiaries, and to all these beneficiaries provide access to secure contracts. We already comply with the regulatory requirements in order to reduce the financial burden and also the legal one. And our turnkey contracts are composed of flexible clauses that can adapt over time of the life duration of the contract, because we propose, for instance, during the contract to integrate new features of the solutions. If the supplier contacts us and offer us the possibility to add some new features to the main solution, we can discuss with him to include them. And also pricing clauses to adapt the price according to the current situation. It's something that might be possible in our contract. And last but not least, concerning the procurement expertise, since 2 years ago, we have the possibility to extend the geographical scope, because we have signed a partnership with a Belgium central purchasing body called Mercurosp, and within this partnership, we offer the possibility to the Belgian beneficiary of this CPB to access to our contract. So it's quite an innovative way to work, because the Belgian central purchasing body, if they would like to offer a specific product to its beneficiary, they can look into our catalog. So it's quite a great way to collaborate between CPBs. And Mercos is a French-speaking CPB, so it's easier for us to work with them, especially also on all the legal aspects. Beyond the procurement itself, the advantage of being a CPB is that we can act in the access of the market for the SMEs and startups, because we can offer the solution provided by the economic operators to a wide range of organizations, and through a single procurement process, because we allow the suppliers to respond once and remain contract holder for several years, and in that way reducing their financial, administrative and reporting burden. So it's quite nice. A concrete example is during in our radar market. Nosotech has awarded three lots, and it's a Canadian company. So being the holder of this contract allows them to propose their two solutions to our beneficiary. And now, since the signature of the partnership with Belgium CPB, they might be also have some users and users, I would say, in Belgium too. So it's quite nice. And more broadly, through the wholesaler approach, because if we talk about procurement process itself, RaDAR supports also SMEs and startups by enabling faster scaling of their solution and facilitating their access to markets thanks to a specific clause, a pricing clause, because as we buy and resell the solution, we have the opportunity to pay the suppliers in 7 days. So it's quite a tight schedule. So it's very important for the SMEs and the startup, and a key lever for their scalability.
Quickly to go back to you, Jordi. So you are also working for a GPO. You were also GPO in the process. You helped the member in definition of the contract and launching execution and so on. You're coming from a different country, but the question is not the same, but is in a way similar. What are the opportunities? What is the added value that GPO can bring to health system industry?
Yeah, I would say it's actually three things: collaboration, speed, and attractiveness. So in collaboration, and we are a GPO that we helped Laboratori de Referència de Catalunya. I would reference them as the lab. And then the hospital that was working with the lab, Hospital del Mar. So we were three partners buying the same. We just helped with the procurement, but the actually buyers of the solution were the lab. But then the change occurred in the hospital. Okay, and we did all this process of change and impact into the hospital with collaboration. So the important thing is that the lab is not only working with Hospital del Mar, so they are working with other hospitals. So the input that they put it in the procurement was also thinking that maybe this solution is not only for one hospital, but can be for more. And we as well as a GPO, we were thinking that this solution is not only with this lab and this hospital, but could be for the whole system. So we work in a collaborative way. And then the speed is because we can collaborate as well with other GPOs, which actually occurred in this project. Earlier today, ECO, which is another entity working in the project, they said, okay, working in this procurement was hard, was difficult. We have to take into account that there is some time of adaptation until you get the results and the procurement you want. We actually entered in the project quite late, so September 2024. But then on April 2025, we had already awarded the companies and the contract was already starting. But it's not because we were good, but because all the people that started earlier in the project, they did really good. It's like entering into a jungle, and then the first entering in the jungle, they were like cutting all the herbs. So then when we entered, we could already run. That's the thing that we do with collaboration. We create a speed, and then we make, working as a GPO, we make bigger contracts, so it's attractive for bigger companies to apply and try to adapt their solutions to our needs, but also as well for SMEs, so for small and medium enterprises, working in this way that they start working with one lab and one hospital, but thinking that they can, in the future, put the solution in the whole system. It's for them more attractive to grow as a company. So collaboration, speed, and attractiveness.
Thank you very much, very clear. And now I would like to go to Mark. Sorry. Mark, yes. So since you're part of Cienzano, which was not the partner of the project and is not a GPO, but you have quite some experience in pre-commitment procurement, right? And can you tell us, from your perspective, what are the key conditions that must be placed in order to move from PCP to PPI, so commercial procurement to the procurement of innovation?
Thank you very much for hearing us here. And I should say, I heard already some elements. It's not a jungle. With us, it's a swamp. So you have to also take care of your sink somewhere, we don't know. But it's true, I think one of the conditions to enter into a situation where you can even think about the PPI is you need a group of people that can work together, that learn to work together, and you need a good idea. That is principle, and it has to be discussed a little bit also with the people that are going in the end pay. So it has to be an interest there. So, but I think what we just finished, or we're finishing together with our colleagues from Aquas, and I must say most of the things we learned from in the PCPs from Aquas, and now we're going to jointly enter into a PPI. Hopefully, we don't know yet, but the thing that you learn is that first of all, there's a lot of people who are not aware of it. So there's very few people that really understand it. And then you have to have a good group of people that identify something that is based on a need. There has to be a need, otherwise you get nowhere. And the thing that is maybe underestimated here is the time frame. Like for our project, we started to think about it in 2017. So we're 2026, and it's still innovative. It's still in the, so what we wanted to have is still in many of the healthcare systems now, people say we're talking about liquid biopsy, very complex liquid biopsies, and they still say, we need some work to do that. And we saw it in the PPI, and that's what we're going to do now in the PPI. First of all, there was many people interested. We almost had to stop because you cannot have too many people in a PPI also, but we have 6, 7 countries that are really wanted to invest, and there's still things to learn, because what we are trying to do in the PPI is what nobody wants to pay for, learning by doing. And you need to be in the clinic, you need to be in the hospital to learn really how it works. And that, I think, is something that really this PPI at the European level is offering us. And it's going to be interesting to see how it works. I'm not sure how it works. We are in 7 different countries, different healthcare systems, different payer systems, different levels of readiness, very important, the readiness. And interesting now, and that is a case now in cancer that is unique for the moment, you have the European Beating Cancer Plan. We are going to showcase what we do in this PPI, if we have it, to other countries who are not even involved. So that's where, in fact, one of the aims of the whole EBCP was to reduce inequalities. So PPIs can really help in leveling inequalities, because you also have 7 countries together. So at the moment they will bring together. I must say, the people that we started with the PCP, we have many projects together now. So that's also something that's, these initiatives that are normally national or local or at your institute, these European projects, you bring countries together, you bring discussion together. So I think you cannot underestimate the, I would say, externalities that you create by having these kind of projects. So it's something that and really what Europe is doing, and the Commission is doing extremely well, is creating these communities. You have to, of course, at a certain moment, they have to realize something. They cannot just be talking, so they have to become concrete. So that's some of the things. I think that is very important to make a success. I'm not sure that we, first of all, we have to pass the call, and then afterwards we have to see whether it gets something. But even just being able to build up together things in the future is already a success. Because it may sound a lot of money that you put in, but in the end, if you look at the cost of healthcare systems, these projects are really not so costly. But the value is in bringing the collaboration together.
Thank you very much. You mentioned the communities, and I'm not sure if you were referring exactly on our project, that is the procurement platform, where we are actually, if you are not aware, we are actually trying to organize communities of public buyers that are around different topics or different communities, and it is actually exchanging the best practices, exchanging the knowledge, connecting someone that has by chance or by mistake done something maybe in Croatia and can teach maybe someone in Germany. And this happens. This is especially when we have innovative things around. It's not that the most developed countries or the ones that are a little bit, how can I be politically correct, further in something that they necessarily have also the best practices. One of the best digital examples in Europe is Estonia. So it's a country that was behind the Iron Curtain when I was born. But you touched about that, and we will go now a little bit more in depth with Olman. You work for Aquas, and you were the coordinator in this project, right? And you work also on the other projects co-funded by European Union. But based on your experience with the European Union projects, what is the single biggest barrier or couple of barriers today preventing wider adoption of PPI in specifically in healthcare systems?
Thank you. I think, well, it has to do with the different levels also of governance, in fact, because PPI, as Mark suggested, is not something people know about. And you learn by doing. So the one thing that it actually makes a relevant case is participating in one gives each actor the experience of having understood in practice what this actually means. And I think, for example, for Reza's case, which had already done so, but it takes, I think this takes in two different levels. At a personal, professional level, each individual that first tries to understand what PPI is needs some time to go through the idea. Then you need to understand if your institution has, also your back on it, and if they do, that's also a good thing, which has been my case in Aquas. Aquas understood, and the Catalan health system for a while, from 2010 and 2012, that we had the capacity with the highly skilled professionals, with healthcare services, highly skilled researchers, that we could generate innovation. So the generation of innovation sometimes is not the hard part. The efficiency of this innovation is not the hard part. The hard part is how do we adopt it, right? And this is a problem for the health system as well. And I think Assunta mentioned before, we have all these dynamics in the system, and there are all these innovators coming up with stuff, and we don't know where to go. So having a proactive activity, a proactive strategy for health systems to say, hey, this is my priority, this is what the systemic challenges that we need to tackle are here, and I present them to you, that helps also sort of the innovation ecosystems to understand it. So first thing then is awareness, knowing what it implies, right? So at HIPS, which is another call by the Commission, is trying to mainstream this instrument, right? And so we need ways. HIPS, it's Health Innovation Procurement Support Services. So in this case, we have a platform that is trying to address sort of the two sides of the formula. On one side, you have the procurer, and the other side, you have the innovation provider, right? But on our case, we decided to go at a higher level. What is the health system perspective on it? And how do we then acknowledge that there might be policies that support the adoption of this instrument as a transformation lever, right? And for us, this is what became truly our aim, to see how can we translate what we do in Aquas within the health innovation ecosystem and what we do in other projects to provide the expertise, but also the support, also the continuing learning by doing that we're still on, all of us, at the individual level and also in the collaborative level that we've managed to have, let's say, in our unit, in our agency, but also in our health system, right? And this means that the community that you were talking about represents how are we mixing this sort of different levels of maturity to address what it would make a successful PPI in the future. So what we did in this HIPS platform is create a lab that it's a PPI Health System Policy Lab, in which we're trying to create a space where people can share the lessons, the experience, and also provide sort of a systematized structure and a framework in which you understand that PPIs are projects. So projects have a beginning and an end, and they have a specific purpose. But they mean they're not, for us, they're adoption mechanisms, but they need to end and they need to generate the evidence, so they push the ball forward. But what we also need are policies. We need policies that support demand-driven instruments like PPI and the adoption of those instruments in health systems. But the other element is researchers and the industry is pushing technology that sometimes it's interesting for us, it's interesting for our researchers, but we don't know how to adopt them. So we also need to create policies that help us understand how do we calibrate this technology push or the researcher-driven innovation that maybe we can leverage if somehow we manage to end up with a PPI case that is getting us closer to the adoption complexities that everyone, all these different stakeholders need for those solutions to become, let's say, the standard of care or the new standard of care.
Thank you. Yeah, you need us as well. So that's but this is also the challenge that I was talking at the beginning: creating policies on something that is really unknown. And here we need the stakeholders, we need the lobbyists, the positive way of lobbyists to tell us what they need, so that we can try to review. And we are reviewing currently, if you know, the public procurement. Whatever is going to be the regulation, hopefully maybe directive, and then also there it's this is the strong and the weak point of Europe. What we create in Brussels is not automatically translated into regional, national policies. We try to align, we try to push, but then of course we like also that we are so different in Europe. So it's a hard task. But Bernice, I saw you nodding on Olman's intervention now. So looking ahead, 3 to 5 years, and I understand in framework of PPI, it's not very long term. It's because it takes time. But how do you see the landscapes in terms of value-based PPI?
Actually, I think you will find all the answer to this question if you rewatch the roundtable, because I think that in 3 to 5 years, success will mean that PPI is not any longer an exception, but a standard practice, because we need public procurement of innovation. We need to highlight innovative solutions that are ready to be used by hospital if we are focusing on healthcare ecosystems. But I know it's quite optimistic, because 5 years is actually tomorrow. But maybe in 10 days and between 3 to 10 days, you will need to continue to invest in capacity building in terms of skills, legal expertise, procurement, and EU project knowledge, because as you mentioned, Mark, the knowing about EU project is key if we would like to have more PPI implement and more deployment of innovative solutions across our organization. So we need to give all the keys. So the project IPS, it's one of them, to the contracting authorities to allow them to design and implement PPI. So I think it's very important to also communicate about the tool produced by the European Commission, by all the consortium, by our consortium, because the methodology that we have developed during the RaDAR project is very interesting, especially for us as a CPB, because this project allows us to participate to a procurement with other profile of contracting authorities. So it's quite interesting for us to learn from hospital, research institutes. It's very important for us because we don't have the same scale, because our structure is more for deploying innovative solution at a larger scale, because we propose the solutions to many beneficiaries. So we can act as a multiplier. So it's quite interesting for us to facilitate the large scale deployment and adoption of innovative solutions, which have at the end impact on care. So I will conclude to take your input, Jordi. It's important for the future of PPI to collaborate together and to learn from each other, and moving forward with our skills and build on it.
Jordi, you were named, so you are the next. So if you could change one thing in the current system to unlock the potential of the PPI, what would be that?
Okay, I'm going for a moonshot now, ¿vale? I will try to explain as good as possible the thing that could change, and then to improve scalability of innovation, because the problem is well diagnosed, and it was mentioned in the table before. And I would just say the phrase that innovation cannot be is difficult to scale when you have a reimbursement system that is short term. Like it's true, and it's explained in the table before, that the Catalan health system is paying the healthcare institutions to do the job, and then if they can do the job more efficiently, then the difference is for the institution, and they can try to be more innovative. But then it has been said as well in the previous one, innovation needs a push to be efficient. And that's why we think about, and Rosanna was saying it as well, long-term goals, medium-term goals that will allow you to go to the long term, and then short term. But the ones that we are measuring in the short term, when you try to change things, is like, are the professionals happy with the change? Do they think it's working? Like, we don't have enough data to prove that it's efficient, and it might not be efficient in only one center, but it might be efficient if we go for the whole system. So, okay, now this was only the preamble, like the context to say that, okay, so this methodology or the process of AMR, of detecting microbial resistance in the hospitals is already paid in the hospitals, okay? But we did a change that needs a bit more of investment. So we need to measure what is the difference between what is already paid and what, and the difference, the increase that is needed, and until when will this increase be needed. So if it's 5 years, we create a fund of investment for 5 years, like investment and then disinvestment. Because if you say that in 5 years, this will be more efficient and it will be already paid, then I create a plan for investing in this and then disinvesting. If it's working, if it's working. If not, you go back to the previous procedure. And this is, I think, what we need to do. And this innovation investment fund, it doesn't need to be filled only with the healthcare system money, like, because it's happening in our country as well. Like, okay, GDP is increasing, but then the healthcare system is economically constrained all the time. But it's because we are putting investment in the healthcare system, and then the beneficiary and the benefits of this is going to the workforce, because people is healthier, so they can work more, and then the country is more productive. So the GDP is increasing, but healthcare system is not getting money back. They are just investing more. So this investment fund must be filled not by healthcare system, but other departments or public-private collaboration as well. We need to find the way to put money in this investment fund. That was it.
Thank you. No. It was not the one single thing. It's a more complex, right? And of course, I understand that, and we are perfectly aware that on its own, the public bodies cannot function. I mean, the future is in the joint initiatives of public-private, especially in some areas. Healthcare system, it's a very touchy system where it's also politically not in every country will be easy to go that way, but that's again depending on the national legislations. And you described very well the complexity, and Mark, you mentioned earlier swamp, right? That you consider it a swamp. And it's a kind of, actually Brussels, Brooks means swamp. So maybe it's because of that. But this is the city where but actually it was dried, and now it's a beautiful, sometimes beautiful, these days very beautiful. But we that we live here, we know also the other sides. Anyway, how we can actually dry the swamp of the PPI. In other words, how can we better demonstrate the value of PPI to decision makers? So you have a couple of minutes to pitch and to show me that there is more value, that we should be doing more well.
Maybe just to pick in on what Jordi said, because he was saying, yeah, we need a fund that supports this. Actually, you could also think about the shared risk approach, because that's what we're now discussing with the pharma on the off-label use of these very expensive drugs. Why don't we take the risk together with the industry? And I think for this innovation, it could be a general way to do. And a little bit the PPI is already doing it, because it's the Commission who takes the risk, not the industry, but maybe we can think of other ways. And that's I think, something that in the AI world, we probably have to do also. And if you now say where the PPI is indeed something that we need to make more extensively and more broadly known, we are going to take it on us, Cienzano, in one of the new initiatives that the Commission has starting and that we are setting up together with the member states, that the network of comprehensive cancer centers. So that will be a network of the major hospitals on cancer. And we will try to push now this idea. We already presented the PCP and everybody was looking at me, what is this? So there will be interest from there, and that's really whole Europe, 31 countries, everybody is there, more than 100 centers, And we are going to try to define together what are the needs of everybody. And then we see who can work, because there's a lot of things that you can do, and not everybody has to do everything, but you can separate, you can, and the needs are different. So, and it will start with PCP, and then in the meantime we can discuss on the PPI. Interestingly, the Commission has only not the idea of creating comprehensive cancer centers, but they want to do it for cardiovascular also, and the Safe Hearts plan that is now coming. Very often, these oncology and cardiovascular are in the same hospital. So it's one shot, and you can continue like that. So this is something where, again, the networks that the Commission is making is offering us really an opportunity for these kind of things. And I think everybody will be interested. Everybody will ask the same question: how will we pay this transition phase? And there I think we are now discussing partnerships with the industry on how we could work together, and I think that is one element that we have to explain, and the industry is willing to do that. But you have to give them also a perspective towards the future. Will it happen, yes or no? And the other element, we can have the industry, the hospitals, but you need the reimbursement payers, the payers also aboard. So that's another element that we, and in the plans that the Commission has with DG Santé, the member states are also playing a role. So we need this discussion also. So we have all the elements. So it's there. And I think now we have to see what comes from the next plan from the Commission. I hope it's very industry-driven, very industry-directed. But okay, industry cannot do it all. They have to come back to us also. So we have to create this not a swamp. Brussels is indeed, Bruxelles is, but it's not a swamp anymore. Well, some places it is, but okay. we are able to avoid them. So it's there. So we can, I think we can go ahead.
Thank you. Thank you. And now my last question goes to Olman, and it is a concrete takeaway. So tomorrow, one concrete actions that stakeholders can take to accelerate the adoption of PPI solutions.
Okay, so we believe that people, for example, that have participated in RaDAR are change agents because they believe in this long-term transformation. So we know we have clinical champions, we have research champions, we have champions at the health system level, health managers. So if they understand that they are part of this transformation because they have complex challenges that they face and they understand they cannot solve them by themselves, what they need to do is find these alliances internally and find the alignment and a broader consensus within their institutions, but also try to see how they can find those alliances elsewhere within their health system. And this is a little bit the space that we are trying to address with this HIPS laboratory, in which we allow those change agents to have a go at this systemic policy journey, in which they understand the demand-driven element that I think we need to focus on, because most of the things we hear about innovation are targeting, oh, we should go faster and get this industry quicker to the market because it's already there. But on the other end, you have the upskill the capacity of this complex health system aligning together to tackle this real big challenges, to participate and co-create and do this risk-sharing design, co-design. And of course, the industry is in it on the PPI formula. So we need to see how we push that part, and they need to be able to understand how to do this alignment of healthcare policymakers, healthcare managers at different levels, local health system, but also national and European, and also this professional healthcare providers, right? Then they need to be able to understand this complex PPI, so that's another thing that we can address. And we need to start sharing tools for deployment, things that can help you get in your first PPI project, whether you're a procurer, whether you're an innovation provider, whether you're a health system. And how do you design these policies that could be reaching out within your health system or supporting your health system actors to go ahead and tackle this challenging processes. So the third element is the strategizing for your local context. So we need to be able to, as Madalena was asking Asunta, we need to be able to learn from other health systems that have done stuff that we can now think about and interact with our own local stakeholders to get those first strategies on board to help demand-driven instruments or to help demand researcher or tech-driven innovation, that it's already there, but we need to find the ways that we can sustainably adopt them.
Thank you. I like your proactive approach, and it almost sounds be the change that you would like to see, right? When you mentioned the change agents. So if I can conclude this thing, and correct me if I'm wrong, there are already solutions out there. We are not starting from zero. There are here and there, maybe not really all in one place. So maybe the first thing to do is to keep networking, to expand the network, to communicate what that is there so that actually the public buyers and other stakeholders can join you, can understand that there is something open. Education needs to be done because actually we have to teach and learn even more how we can do it also in the public buyers. The policy should proceed, but will probably follow up. And this comes to what you suggested also in your intervention lastly. We need an integrated approach of the public, private, public, when I mean public, it's public buyers, private, and institutions that are public but not as meant as public buyers, but the ones that facilitate this whole process that probably in Europe we need heavily more than in maybe in the States or somewhere else. This was it. Any other quick comment from the... No, that was it. Thank you.